each one is from a different hospital. There is no group with each other. I saw Dr. Luai, Dr. Hammam. You know each other, huh? Okay. دكتور عدنان، مفيش حد من زمايلك هنا؟ same Emirates. Okay. one دكتور محمد وحيد دقاق عظام. في حد من زمايلك هنا؟ الدكتور اللي جنب حضرتك اسم الكريم؟ دكتور عوض ودكتور محمد ودكتور أحمد، مستشفى مع بعض. That's great. One of the targets of my training activities is to make us know each other, because this knowing considered one of the marketing, and the marketing will deliver our value to people, our value, our pocket money. This will deliver, they will reflect on your work to know each other. This is very important. Sometimes I do this case and I send the case for you, and you are seeing another opinion. If there is a struggling, this is not good. We should be a team. First point is we are here to entertain our training. Second point, we are a team. Third point, which is in interactivity. Like, I will start by this interactivity, not by this title. You know, if you open the internet, you will see 100 million of lectures that will be better than me. Okay? So that, let me to ask one by one. In doing ultrasound injection, this is our core objective of the day. Ultrasound guidance for injecting a joint. This is the core of the day. I should deliver to you my experience, how to control the needle, how to see the tip of the needle, how to be safe 100%, not save 95%. You know, joints are usually, alhamdulillah, it is not so dangerous, but sometimes you may see an artery in front of your trajectory. Sometimes how to control that points. So that, let me to ask one by one. Ahmed, I can ممكن اقعد اقف ولا ما ينفعش؟ يعني اتحرك يعني، اصل انا مقيد، حاسس ان انا عايز انطلق كده انطلق. بما ان هنطلق دكتورنا الفاضل دكتور محمود، صح؟ محمد. عظام. بتشتغل ايه في السونار، في الالترا ساوند؟ So that my question for all of you are working in ultrasound or not? دكتور عدنان اشتغل ultrasound، صح؟ musculoskeletal. You know the anatomy. You know the differentiation between fluid and tissue and the joint and the ligament and you know this. طيب دكتورنا الفاضل محمد اشتغلت سونار؟ بتشتغل سونار كويس، وحطيت معاه ابره وبتشوف الابره رايحه فين، والتيب اوف ذا نيدل كنترولينج ات فيري ويل. كويس. دكتوره مليكه، your name is شيماء. Okay, you are so welcome شيماء.
Thank you.
You are welcome. دكتور الفاضل عوض خالص. الالتراساوند بيزكس. You know anisotropy artifact. anisotropy artifact دكتور عدنان. artifact ازاي تشوف الصورة كويس. What I'm doing now, I'm doing pre-course evaluation to enhance my training objectives to all of you, so that I will ask one by one. دكتورة ولاء بتشتغلي سونار؟ controlling needle كويس؟ to some extent. That's great. Doctor? You work in ultrasound?
Not much.
Not much. You know how to see the needle?
I have some basic idea, but I'm not doing it regularly. Like, say, we have a radiologist, so sometimes they help out, and then that's how it is.
Okay.
But I want to do it on my own.
That's great. Doctor? Your name first. Pavan.
Oriana Hospital.
Yes.
Yes, I don't do routinely in my outpatient clinics, but I have experience. I do fast.
Fast?
Yes, ATLS
That's
trained.
great.
Yeah, and I do joints also, but
Very
not often because I don't feel any big advantage.
That's good.
In the common joint where we give injection like knee
Yes.
and all.
But you can inject the joint without ultrasound?
Yes, absolutely. Yes.
All of you are orthopedics.
Yes,
That's
absolutely.
right?
Yeah.
You know the surface anatomy and.
Yeah, yeah.
And if you inject without ultrasound, you know how much the percentage of accuracy? 60. By using ultrasound, the percentage will be nearby 100. Nearby 100. That's great. That's great. Let us to jump to our colleague, Dr.
صباح خير.
صباح الأنوار.
أسامة البطل أورثوبيديك
بطل.
كونسلتنت.
فلتكن بطلا معنا اليوم.
إن شاء الله. يعني I used ultrasound for the last 5 years only for the baby hip ultrasound.
Baby
only.
hip.
Yeah.
Good.
Only.
Good.
So just to rule out
But
hip,
no
hip
injection.
dysplasia. No injection.
No injection.
No injection. I'm using the injection without ultrasound, and the results are fine and good and satisfied, and the patient also satisfied. So why I have
That's
to have long procedure and it will be the same the same result.
Okay, that's great. Let us to jump دكتور اسم الكريم.
Dr. Ahmed.
Ahmed, تفضل.
No, I'm not regularly doing any ultrasound injection, and I didn't have any practice regarding ultrasound
That's great.
injection. Yeah.
That's great to know that.
Yeah.
Thank you, Dr. Ahmed.
So I'm
دكتورة.
really interested for today.
دكتورة.
Hi, I'm Dr. Maya. I'm a radiologist.
Radiologist.
Yes, yeah.
That means you know MSK or
So, yes, I know MSK. and
you have experience in injection or not?
No, I just came to learn that, yeah.
That
I had attended one course before, but I want to do this again.
yes, that's great. You are welcome, Dr. Maya. Doctor.
Dr. Ahmed, radiologist. I do limited ultrasound, usually almost like his MRI report.
That's great.
Yeah.
Do you have experience to correlate MRI findings, for example, shoulder, with ultrasound?
No shoulder.
If you put this in your mind, by time, this will make an effective work with you.
Yeah.
Actually, you can minimize the number of MRI by using a good MRI of the shoulder, ultrasound of the shoulder.
But the problem, he doesn't like to minimize the number of the
Yes, we are talking about quality of work, private work. So that I have more than one lecture today, but I don't like to go 90% to the theoretical. I need to be 90% in the practice. This is hands-on training course, but I will give you some points to maximize your benefit from private work by using joint injection. You know, joint injection considered one of the pain management. So that if you make it very quick, if you make it confident, accurate, you know, quick as reasonable. If you make the 3 core objectives in your hand while working in your clinic, this will make a good marketing for private. We will talk about this in some time of the day, but let me to jump to Dr. Hammam. I know that you are starting to work in ultrasound.
Yes, in fact, I do injections, but I don't use ultrasound.
That's great today because we need to use your experience how to inject joint by some questions during the day, inshallah. Dr. Wael?
Same, we usually give injection, but without ultrasound.
Alhamdulillah. Who is Dr. else?
Kabir Abdul Qadir from Ras Al Khaimah, orthopedic.
Ras Al Khaimah.
Yeah.
Orthopedic.
Yeah. I have just attended a few courses of ultrasound, not done any injections through ultrasound.
Here I will highlight on some words. Ultrasound is an issue. Injection or guidance using ultrasound to guide the needle, this is an issue, another issue.
Yes.
So that my issue today, or my core objective today, is making all of you, inshallah 100%, all of you, at the end of the day, to be safe, to see that the needle the needle tip, the needle like that, like that, like that. On in vitro hands-on training, this is the first step to jump after that to do on a real patient day by day. And we started today to be as a team. Never we will forget you. We will make a group on on social media. This group for this number of doctors, and we will follow continuous training. When you do case, please put it in that group, and we will make an interactive, continuous medical education. Okay. This was, I don't like to, any doctor more? Sorry, doctor?
Yeah, I'm Kiran, I'm an orthopedician. I'm a hand and upper limb surgeon.
Orthopedic?
Yeah, I'm a hand and upper limb surgeon.
Ah.
I routinely use ultrasound guided injections. I'm very comfortable with in-plane techniques, but out of plane, I'm not very comfortable because
this is good. Why?
We don't have access to MSK probes usually.
Ah.
So we have to work with the large probes, and in plane sometimes it's difficult. I don't use ultrasound for major joints, but I use it for
today I will, but remind me, inshallah, on the model, I will make you 100% confident in out of plane technique.
Okay.
I know your point of defect at that point exactly, because you teach it the way of in plane without basics. They're a great base today. After that base, you will be confident, accurate, quick as reasonable. Inshallah. Any other doctors? Dr. Heba, you are welcome. Dr. Heba, بالله على السلامة.
الله يسلمك، منور دبي كالعادة.
الله يسعد أيامك. بتشتغلي بايوبسي ولا لا؟
لا، لأنه الرخصة بتاعتنا general radiologist. البيوبسي it need to be interventional radiologist.
رائع.
But we are guiding the orthopedicians.
You are a team.
Yeah, teamwork with the pathology and the orthopedic surgeons.
That's great, and you are welcome, all of our colleagues today. Inshallah, we will make it a good day. And before going directly to the core lecture of the day, which is ultrasound guided joint injection, and we will pass through the major joints: shoulder, elbow, hand, hip, knee, ankle. Will not go deeply through the dedicated anatomy, ultrasound. No. We need to go to the core objective of the day, which I will explain it to in this 10 slides lecture. I will start to show it to you. I named that lecture the core. Because of what? Because usually, like I said from the start, we are doctors. Our time is spent all of our life to read the book from the start till the end, to read, to take more theory, to upgrade your skills. But here I will be beside that to our core objective of the day, so that let us to read. I think all of you read that advertisement for that course. Okay, we will follow the schedule as we can, but at the end of the day, the objectives will reach to all of you, inshallah. So that first session, pre-course evaluation, we finished it now, and by this session, I mean to build new leaders from this course, Doctor. Which is anyone expert need by time to have to be a trainer. One of my my objectives to push the new leaders in the field. At the end, yes, we are making a good healthcare quality. So that I need to next course, inshallah, I need some of you to be with me in explaining that to others. Put this in your mind. I will go outside for this to give you some stories. And the story, I'm not in lecture now. The story in teaching, it is raising the health, raising the quality of teaching. So that I was radiologist, junior radiologist like these young doctors. Then in the career of Al-AZHAR University, then started to be lecturer, assistant professor, all of this my way. Yes, I am academically, I know how to teach, how. But in the last 10 years of my life, I concentrate in training. And the training is a good business for all of you. Put it in your mind, sideway business for you. And this business is good with God and to help people. And it's good also to make money for you and to raise the private hospitals to catch you like that. I think this point I will explain it along all over the day to make it clear for you. Let me back to this program to assign our time. Ultrasound principles, basic clinical review. Never to work in ultrasound unless you know some basics, very important. To direct the probe like this or like this. Now I am cam degree. How you know it is 90? How you know? By logic thinking, by guessing, so that we will make during the day enhance your guessing ability during seeing the needle, so that if you make like this, the picture will not good, because this is B mode. How to know that? I will explain step by step, inshallah, in basic principles. Then interventional ultrasound guidelines. The guidelines are present in internet. I picked some points very important to you to follow the guidelines, to follow the quality, and then we will go to the major core of the day, which is the lecture to simplify the process of ultrasound and the needle and the correlation between both. Then we will start to work on the model, and each one of you will work in front of me, and I will catch his hand to assign the core I will tell you in this slide. Today I need to give you 3 points. I should give you some knowledge. You know better than me. You are orthopedics mainly, and even radiologists, you may read more than me. This is normal. I will give some skills and some experience in the point of controlling the needle and the needle tip to be safe as you can. And remember, if you take these basics, you can do any intervention by any ultrasound, not only in joints. You will use it in another. Sometimes you may need to drain an abscess. You are orthopedic doctor, and one patient came like that. You need to see the abscess, which is 3 centimeters, for example. You need to hit this abscess. How to hit? I will give the base today to use the benefits of seeing the needle. Then, by using the knowledge, skills, experience, I will make you confident, accurate, and quick as reasonable in what? This is the core of the day. So some main objectives in this training course is focused to needle tracing, tape visualization for the beginners. عشان كده انا بقى الدكتور عدنان والناس الطيبين اللي هم anyone expert, don't feel that this day is boring. You may feel some time like that, but you can initiate from me some questions. This will make you satisfied. Ultrasound, understanding ultrasound fundamentals, transducer selection, which probe is better. Okay, now we know that ultrasound is become handheld, and all of you will use handheld in this year or the coming year or the next year. This is mandatory. خلاص. The ultrasound becomes handheld, and bilateral يعني low frequency or high frequency, you will use that without any wire. خلاص. In emergency, in orthopedic, in intraoperative, this will be the era in the coming years. So that understanding ultrasound fundamentals is very important, to know the difference between transducers and to know which frequency is better to your level of joint. We will see this. To master needle visualization technique using in-plane and out-of-plane technique. What is in-plane? What is out-of-plane? I will go through this a long time, inshallah. Develop needle tip tracing skills. to take the skill today, it is my job. So that you will take this skill, inshallah, perform joint injections. We will do joint injections, but not in human. But this will make you confidence in real patient injection. Ensure patient safety. This is very important. You will ensure the patient safety by seeing what nerve beside the berza. For example, you will go to the berza through a nerve. This is not allowed. You don't be advised to hit the tendon like that. How to know this? We will ensure this by some videos and by using the hands-on training on the in vitro model. Improve efficiency in real-time needle manipulation during ultrasound guided injections. All of these I came today to deliver to you this. More important than knowing the anatomy and. Sorry for that, but I know the importance of this point, especially for the beginners. Troubleshooting sometimes you may meet some challenges during injection. We will try to describe some of this during model A. Look to this video. We'll start now to build what? To build the orientation of the needle on scientific beats. How? This video is not for joints, but it is come to understand why this needle is not seen in injection. Sometimes you put the needle, you are inside and hitting the joint, and you cannot see it. Why? Because of this video we'll see. Now we will start one of the important points in the day, so that if any question, stop me, ask me, and this is an interactive training. Here, to move the probe, there is guidelines moving the probe, international guidelines. We will see it step by step. This video is from YouTube. Okay, many videos just to highlight the importance of the
when discussing ultrasound guided.
Look to this one. These are vessels, nerves, tendons, whatever. Consider it like that, and the probe should move in that directions scientifically.
Peripheral nerve block technique. It is useful to describe basic nomenclature for needle and probe manipulation.
By the way, you see this plane of image?
Much of this is derived from the American. It is useful to describe.
Like what? It is named out of plane. So that I will explain what is meant by out of plane and what is meant by in plane. This, if I cut this wrist joint like that, transverse, the image will come to you rounded. You will see the image on the machine rounded. Okay? If I cut it like this and the needle go through this plane of image, the needle come from here, from this side, running in that plane exactly. This plane is at least one portion of millimeter. This is very, very narrow plane, so that the needle should be in plane, so that we name it in plane technique. What is meant by out of plane technique? Out of plane, the same, but I will go from here, perpendicular to the other. This is out of plane technique. You will see this now.
Basic nomenclature for needle and probe manipulation. Much of this is derived from the
American Institute of Ultrasound Medicine. Every year they make a renovation quality guidelines for using ultrasound, and more than one society make like that. But this is a common one, and we follow it in many guidelines.
Institute of Ultrasound in Medicine standards. We will describe the two basic scan planes, the 5 probe manipulation maneuvers, and the 2 needle approaches. In the following figures, we are looking at a schematic of an ultrasound transducer applied.
Here we cut this organ, which may be vessel, maybe tendon, maybe nerve. We cut it transverse, short axis. This is another name. If you read in book, short axis view, transverse view, it is like that. The image will come like this. Because it is running or going to hit the organ perpendicular, 90 degree, you will see this wall of the vessel or wall of the tendon or wall of the nerve or the tissue. We will see it very well. Follow the video.
To a tissue equivalent phantom with 3 different embedded objects. A depiction of the ultrasound screen is inset. We generally image long cylindrical structures with an ultrasound beam that is essentially planar. Short-axis imaging cuts this cylinder transversely, revealing a circle. Long-axis imaging cuts
the best image of ultrasound clear, and you can see the fibers of the tendon very well, to be 90 degree while scanning. This is the best in all P mode ultrasound. And I will give you another lecture quickly to know what is P mode, what is like that. But to remember this, to put this in your mind while using the probe during injection, remember to see the vessel, to see the tendon very well, you should be perpendicular. Okay? If you make like this, you will not see very well the structure exactly, texture of the organ. Let us to continue.
the cylinder longitudinally to create 2 parallel lines. Long-axis imaging is of limited use in ultrasound-guided peripheral nerve blocks.
For nerve blocks, but for you, the long axis for injection is more common. We will use it on, about 70% in almost all of relating to the anatomy of the joints. So that the long axis is very important, and we will see step by step how to use this.
An ultrasound transducer can be rotated or translated along any of its 3 axes. Hence, we need to use the AIUM standards so that we can communicate clearly with one another.
This is a little bit theoretical, but you should know that the probe movement may be rotation, maybe sliding. This is sliding, sliding. This is rocking, rocking. This is compression. These are guidelines. You are using this during using ultrasound without knowing that this is a guidelines. 5 probe movements, know it, but I will jump for the most important point.
Another. Here we see an ultrasound probe movable maneuver that has numerous effects. First, veins or deeper compression is a use.
This is the sliding movement.
Compression is a useful maneuver that has numerous effects. First, it moves the active face toward deeper structures to make them appear more superficial. It also helps differentiate between different structures by their relative compressibility.
Here, this is an image of ultrasound, and the probe is coming from here, from this side, okay, like that. These are organs. Here, some artifacts. What is that? This is an air. But look to the target of this video.
Veins are easy to compress, arteries are somewhat compressible and pulsatile, and nerves are fairly incompressible.
This will help you during injection of some areas in joint injection. Sometimes you know the anatomy here, there is an artery passing or vein, and your tip of the needle beside that. If you make compression, you will close the vein. The artery will not. The nerve will be beside. The correlation between the 3 should be in your mind. This will help you during using ultrasound.
Rocking allows us to extend
I
access
like to jump to the most important
nerve fascicles. It's orthogonal to the course of the nerve. Transducer tilt to properly visualize nerve fascicles.
This now is making what? Making a tilt. This tilt, look to the vessel or the structure or the nerve. It is not clear, but look here, it is clear. Why? Perpendicular. This is a great base in using ultrasound. If you need to see some or any organ all over the use of ultrasound, remember which ultrasound is the plane, is the black and white ultrasound, not the Doppler. Color Doppler is the opposite. Color Doppler, if you make like this, is blind. Every information coming is wrong. But in using the ultrasound black and white, if you make like that, خلاص, the image will be lost. Look to this tilting, what it causes.
Allows us to scan along the course of a structure through a narrow acoustic window. In nerve imaging, it is critical to optimize transducer tilt to properly visualize nerve fascicles. Nerves are seen best when the scan plane is orthogonal to the course of the nerve.
Look to what's happening in that region.
Given that nerve fascicles,
again in that area,
nerves.
Look to this region. It sometimes come good to see it, and sometimes lost. Why?
Are seen best when the scan plane is orthogonal to the course of the nerve.
You see, it is lost. I will show this in the
Given that we are most
okay, the most important is the coming portion of the video. This is very important. Okay, needle visibility, very important.
Interested in nerves imaged on short axis, we will now look at how the needle will be seen as it approaches nerves. With the out-of-plane needle approach, the needle starts in front of the plane of imaging and advances until it crosses the plane.
What happened here during the out-of-plane? We name this way of injection is out-of-plane. What happened? The beam of ultrasound will show you the needle, only a tip of the needle you will see, not all the needle. Sometimes you are going to inject an artery or renal biopsy, like you said, to aorta. Sometimes you are going to hit the tendon and to damage something, and you are not seeing the tip. So that this is the disadvantage of using the out of plane needle, out of plane technique or approach. So that at this moment, the tip is only seen here like this tip. Where is it? Sorry, the shaft is seen here as a tip like that. But where is the exact location of the tip? It is beyond that region, beyond here. And this is not recommended for you to use the out of plane unless some points I will show it on the model.
Of imaging as an echogenic dot.
This is the
With the in-plane needle approach, the needle is visualized on its long.
And this is the most important approach, which is very important. I like you to use it in all of your injections, in all of your biopsies, as you can. Okay? Look what's happened.
As it advances within the scan plane.
Now you are seeing the shaft, and you are seeing the tip, and you are seeing the bevel. All are seen inside the plane. So that we name it in plane. And now you are accurate. You know where is the tip. It will hit the organ or not. So that this in-plane method is very important.
Now let's move on to show some of the common challenges with visualizing the block needle sonographically. Block needles are specular reflectors.
Now, sorry.
Between the
now we are
sonographically.
Here.
Block needles.
Remember, here we will see that the needle very well. Why? This I mean to deliver it to you. Because all of the beam of ultrasound coming perpendicular to that line. So that the images will be formed 100%. Okay? But let us see this
specular
in real.
Reflectors, meaning they reflect sound back to the receiver over a narrow angle.
At this moment, when we make this angle, some of the reflectors will come to the probe, and some of the reflectors will go outside. So that at this moment you will not see the needle, the shaft. You will see portion of the needle. Because of what? Because it is not 90 degree, and some of the echoes are going outside, like this. Look, if I'm like that, you will see it very well. If I make it like this, what you should do? You should do by your hand to go like that. The aim is to be perpendicular. This is one of the core points you should understand during the injection process.
As the angle between the transducer and needle increases, less sound is reflected back to the...
One time I was doing I was doing by probe, which is not like that. I will explain to the probes to you. But I was doing an aspiration of abscess from the psoas muscle. I was beginner. I put the probe. I'm trying to see the needle. Where is the needle? Where is the needle? I don't know that base. So that this base is very important. I exert a lot of time at that time to know. My senior take my hand and tell me, don't be like this. Go like that. To be perpendicular, you will see the needle.
Receiver, and the signal becomes weaker. We can also see that this is true for sound reflected off the sides of the needle shaft. With the short axis out of plane approach, the needle will be seen better.
Look to the short axis, means the transverse or out of plane method. You will see the needle like that. It is the shaft. We don't know the tip. Where is it? Okay?
When the tip is within the plane of imaging. The shaft gives a signal that may be no stronger than surrounding structures. Generally, tissue displacement is transmitted far enough along tissue planes for the operator.
And this is important to joint injection. Sometimes you put the needle, but you cannot get it in the image. If you push the needle, you will push the tissue. Tissue movement will give you information that you are nearby that region. So that don't make more injection unless you be sure by the tip of the needle visualization.
To get a sense for the trajectory of the needle.
We think that
this
the
is a
needle
dynamic
here.
process and relies on the operator's ability to detect tissue displacement created by needle movement.
Remember that this is a vessel and you are beside a vessel. If you see the movement of the tissue like that, try to make it not in plane, because this is out of plane. Try to make it in plane as you can. This will make you save more.
Staccato movements should be avoided. Needle
Sometimes
position
water
can also be
or
inferred
injection,
by
you will
observing
see
the
the
distribution
fluid.
of small test injections and making needle adjustments. Often, slight tilting of the probe can be used to locate and follow the advancing needle tip.
Okay, while using out of plane technique, if you are in mandatory, you should use it. This will meet you in the joint injection. Sometimes you will see the joint is very superficial, and you know your needle will not go through, at least it will go 1 centimeter. Khalas, we know the depth. I will not go more than that. And you need to see the tip. What you should do while using out of plane, not like that. As you can, try to tilt the probe with the needle, or either the probe or either the needle like that. Try to make them near each other. Meaning what? Trying to make the needle inside the plane. It will not come 100%. 100% you see it in plane method only. But in out of plane, not 100% to see the tip. Try to make them like that. Huh? If you make like this, you will be away of the target. Put this in your mind.
In-plane needle manipulation offers its own set of challenges. Here is a sonogram of a block needle with the transducer sliding in and out of alignment with the needle.
While injection, sometimes you may see the needle like that. And some artifacts in ultrasound physics, you will see the needle 2 times or 3 times. You will see this. Why?
Subtle movements of the needle or transducer can produce marked changes in visibility. This pair of sonograms shows the same needle at different angles in a water tank.
The needle is passing here through the water, okay? But you cannot see it because the reflected echoes not going direct to the probe, so that it does not give you image. But here, because it is near 90 degree with the probe, it gives you the image.
Needle is much better resolved when it is inserted at a shallow angle relative to the transducer. The next set of problems occurs when the needle trajectory strays from the plane of imaging. If the needle crosses the plane of imaging but does not completely...
I need to give you point because I will highlight this point here.
Movements of the...
Try, all of you, try to put your eye on this region only. You can see the bevel or not?
Needle or
you see the bevel? You see where it is directed. Going like this or going like this. This is very important during a joint injection because sometimes you go to the space, the known space of the berza or it is a potential space, not open. It is two layers over each other, and you need to inject inside, not outside, so that you should know the tip of the bevel. If you know the tip, you can rotate the needle to direct it toward the area of anatomy you like to give the injection inside. You understand? So this is the importance of seeing the tip, seeing the bevel.
Transducer can produce marked changes in a water tank. When the within it, only a portion of the needle will be seen.
Look to this one of the challenges.
This can give a false impression of the needle will be seen.
Again, like that. The needle like this. Now it is in plane. All of you see it. Okay? Now it is in plane. That means it will appear all over the image. But if I make it like this, and you are like that, you are not seeing the tip and not seeing the whole shaft. That's right? You understand? مفهومة? All of this I will explain on the chicken, but understand with me. By this way, the image like this, the probe in plane, the needle is in plane. In plane means what? All of the tip, all of the needle is seen in the image. But sometimes during injection, you are moving so that your needle like this. You will not see the tip. Where is the tip? It is outside. And also the shaft is not seen all. This cross-cut artifact. This artifact is very important. How to solve this, or how to overcome this? By using like that. Tilt the probe like this to be in plane. Type. If you tilt but you are away of the target, go back by the needle. Don't go more under the skin and try to pick the lesion or the joint inside the image, then direct the needle in plane. This, we name it freehand ultrasound guidance. This way. Its name is freehand I'm adjusting this and I'm adjusting this. The more important point, don't play by the needle more. You can play by a probe, no problem. But if you insert the needle, don't play more. To be more safe as you can.
This can give a false impression of needle depth that can lead to complications. Alignment issues can often be addressed by leaving the needle stationary and manipulating the transducer until the tip of the needle is imaged. The needle bevel has a characteristic stair-step appearance that should be sought out. This concludes...
I hope I give you some points in a model. Let me to apply in a tissue. Okay? Step by step building the...
Welcome to another health...
Try to concentrate in this. It is from YouTube. Just to highlight on the more important core objectives of the day.
Welcome to another Halcyon ultrasound training video. This video will provide some tips for optimizing visualization of the needle with ultrasound. Practice is key, the most important variable for needle.
After today, if you are not using what we talk about, you will lose day by day. After today, you should start to do in vitro. Okay? Bring a if you have a machine, bring a chicken with you and try to 1, 2, 3, 4 times the chicken. You will see joints. Go to the joint, inject, and. This will build you quickly, quick as reasonable, to be confident during real patient work.
Visualization is the operator's skill in aligning the ultrasound probe with the needle. It takes considerable real-time scanning practice and experience for successful performance of ultrasound-guided interventions.
I am sure here, from the tip, it is implant
Practice
technique.
with phantoms or in a water bath. Here we see reverberation artifact.
Reverberation artifact. You will hear this many times in using needles. Look to this needle. The exact needle size is 1. You will see 1, 2, 3 like this, repeated. We name it reverberation artifact. Its cause is, to know the cause, to understand, you can manage. When beam come like this, hit this organ, which is the needle is very reflective, highly reflective. Means what? It sends the first wave of ultrasound. Okay? It hit the needle. Then the first returning wave will give you the exact image of the needle, the true. But because of this high reflectivity and the machine, there is also a tissue in the machine, plastic or whatever, metal, whatever, this tissue will make reflection of the echoes again, not from the machine up, no, just from this surface, so that it will reflect another echoes and will hit the needle. Then the second wave will give you the second picture. This is what we name. The third wave will give you the third picture, like this. While this 1, 2, 3, 4, 5, we name it reverberation artifact. And one of the scientists in 19s used that artifact in the field of intensive care by lung ultrasound. He make his name is Liechtenstein. He make the whole subspecialty of lung ultrasound depend upon this type of artifact. This just to tell the radiologist, you know that. Okay?
From the
reverberation,
hollow shaft
خلاص,
of the
we know it.
needle. When inserting the
In-plane
needle
approach
in an
again.
in-plane approach, the needle is inserted parallel to the ultrasound beam. With the in-plane
Now this needle inside an organ. This organ may be vessel, maybe nerve, maybe nerve. We will not inject the nerve. We inject around. How to be around? You should see the bevel. You should see the tip. If you are confident from this, you can inject around.
approach, the needle is seen as an echogenic white line. Here's another image showing the needle in the in-plane approach. When using the out-of-plane approach, the needle is inserted perpendicular to the plane of the ultrasound beam. It can result in poor visualization because the angle of approach is often more parallel to the beam. With the out-of-plane approach, only a short segment of the needle is visualized. Here we see an image with the needle shown in cross-section.
I need to ask a question.
Here we see an image with the needle
At
shown.
that moment, if you like to see the more portions of the tip, what you should do? Tilt the probe like this, okay? You will not see it 100%, okay? But you will be nearby 100%.
In cross-section. Here, the arrow is pointing to the needle in the out-of-plane approach. We'll go through some tips to optimize needle visualization. First, larger needles are easier to see. Remember to place the needles perpendicular to the beam rather than parallel, and set
focal zone, setting the needle tip depth. In ultrasound, and we will show this in the machine, there is button named focus. Because we are using usually a superficial probe or high frequency probe which work upon about 3-5 centimeter depth, sometimes the focus will be here or here or here. Adjusting the focus will help you as operator in joint injection.
Set your focal zone on your machine to the correct depth. The needle tip's beveled and irregular surface is quite echogenic, so you'll often see the tip even if the shaft is not seen well. It can help to insert the needle with the bevel pointing either towards or away from the transducer to create a little more reflection, enhancing the needle tip. Also, rock or slide the transducer back into the needle path if it
one base, very important. If you are not seeing the tip of the needle in the exact area we need to target area, don't play by the needle. And this will happen with you. You will play by the needle many. Don't play by the needle. Try to play by the probe as you can. Okay?
reflects out of the image, rather than trying to move the needle. Injecting a small amount of fluid can also enhance the needle tip, and introduce the needle in short in and out motions to cause tissue deflection and make the needle trajectory more discernible. On your ultrasound device, a few settings may help. First, lower the dynamic range, which will produce a little more contrast.
Dynamic range.
You can also try reducing the speckle reduction.
I will show it in the next
and
lecture
set the focal zone
control
to the
very well
depth.
the machine.
And sometimes putting the multi-focus.
Controlling the ultrasound machine is very important, and the image orientation very, very important during any injection, whatever, in the neck, in any area. To control the machine is very important, and this is one of the targets today to help you in that.
To the on position will help.
Look to this.
Remember, if you've moved out of plane and can't see the needle, to slide or rock the transducer back in.
Here you cannot see the needle very well, right? Right? سؤال, question. انتوا شايفين النيدل كويس? You are seeing the no, but you know the pathway, it is running like that. You are going to go deep, but you are not seeing very well. What you should do? Not move this, just very, very tiny movement. You can see it.
Position to enable to see the needle properly. With practice, you won't have any difficulty inserting and visualizing the needle under ultrasound guidance.
Okay, I think I put some basics regarding in-plane and out-of-plane and some ideas about using 90-degree and like that, but let me to emphasize on the tips of the core objectives of the day. This video is very important.
Approaches to get some of the.
We jump now to a patient, to take some tips.
Approaches to get a good image using the transducer is, as you place the gel, is to identify structures that you're familiar with. So, for example, in this view here, my finger is right on the epicondyle.
First point is use your talent to assign what you know as an orthopedic surgeon, and as a radiologist, try to use the clinical talent to make you more sure while you using the injection.
A bony structure. So I'll put the transducer right on the epicondyle so that I can identify that bony.
Remember that one of the basics or one of the concepts during injection all over the joints. Try to be longitudinal. Longitudinal is used more than transverse. I know some areas transverse is mandatory, but the general concept, longitudinal for the organ, will give you a better visualization of the anatomy, of the pathology, of the pathway, of comfort, to make you comfortable during using the needle injection. Just a hint.
Landmark. The other angle to, or trick rather, to evaluate a transducer is to make the transducer as perpendicular as possible to the tissue. If you were,
as you can, try to make the perpendicular concept or 90-degree concept to see this line very well, to see these tissues very well.
To bevel the transducer.
Now he make tilt, but the type of tilt, look to this one. I am transverse. Am I right? Transverse ولا لا؟ كده ايه؟ longitudinal. طيب كده tilt. But this is cephalic tilt, going toward the okay? And this is caudal tilt, okay? This also is a tilt, but we name it rocking. Tilt is to be moving along the long axis of the organ, okay? This is longitudinal tilt. If you make not rocking, if you make mass like that in the same point, and because of that I give you the guidelines of probe movement. This one, like this, not rocking. It is called tilt, but longitudinal tilt. But going to see the whole. For example, I need to see the radius. I need to see the whole radius like that, or balash radius. If we need to see that tendon, I need to see it like this and like this. Look to the visualization or the accuracy or the texture of the tissue while we are using this movement.
In this fashion, in a forward-leaning fashion, or in a backward-leaning fashion.
You see, where is the tissues? Because you are away from 90 degree and away from the perpendicular concept.
You lose any appropriate images that you would otherwise have.
You see, when it comes back, look to the.
You lose any appropriate images that you would otherwise have
came very good because
in
you are
the epicondyle. So again, as you make it perpendicular, you capture all the appropriate landmarks, radial head and epicondyle there, as you can see in this view. If I were to bevel it
the benefit of that point concept in your mind, be perpendicular as you can for the target area you need to see, okay?
Forward, you lose the bony structures of the epicondyle. If you bevel it in the other fashion, you again just capture a lot of subcutaneous tissue and muscle. The other approach is not to put pressure on the forward or the backward part of the transducer. If you were to do so, you would get some false images of disease, also known as anisotropy. As I'm moving it forward here, I'm getting.
I will show you this isotropy artifact very well on the model, because very important to you to see the
darker region on the left side of the screen. If I put pressure on the proximal end, I get some darker regions of the screen on the right side or on the distal part. So it's important to be well balanced and to have the transducer as perpendicular as possible. Another trick for that is by placing a couple fingers.
Look to this, another trick during using injection. Look to these fingers. Sometimes because you are using the other hand to inject, and this you need to adjust the image. Put two fingers to fix the probe, to fix that area of the target area in the image. Don't let it to move. This is a tip. You will use all of this today.
My fourth and fifth finger here are placed on the patient itself, and this is used to anchor the transducer. So any movements that I make are very controlled and methodical. So it's a very gentle, simple sweeping, either down the plane or up the plane, or again, in this case here, we're looking at the radial head and epicondyle, forward and backward in an anterior posterior view.
I need to ask a question. In that image, in that location of the probe, if I need to inject this region or this joint, for example, in plane, where I put the needle? I put it from here, or from here, or from here, or from here? Yalla. Here, here. Okay. You may use this way, or you may use this way. This will make it in plane very well to see the needle coming from here to that region, or coming from here to that region. According to what? According to the anatomy. If there is vessels, or if there is something in front, if there is, which is more nearer, okay? These solutions will meet you, and the challenges by using the chicken today, you can overcome these challenges before going to real patient. I hope I explained some points, but let me to remind you what I should apply with you for needle tracing, inshallah, on the chicken. Tip of the needle needle bevel, locate the tip of the needle. Where is how to air presence will help you or will mask you. Will help you after injecting. You see some air at the site of injection. You know that the bevel is at this region. Now it is helping you. But if the air is masking the image, it not help you. So that you can use artifact sometimes to help you. This one of the points. Finger fixation 90 degree. All of this will be explained on the on the practical session. And I know after 14 minutes usually the attendees becomes to be lost. This is international points in theoretical lectures. So that all conferences give you 10 minutes no more than 15 minutes. I will jump to the basics of ultrasound, but I think you need some break, huh? صح? You need another lecture will take about 30 minutes. Feel free. We are coming to entertain our day, to enjoy our day. We are ready? Okay, let us to entertain by the most entertaining time in the day, which is I will welcome my boss, Dr. Ahmed Serafi, and his mother. ما خدش بالي. الحمد لله على السلامة. الحمد لله على السلامة. دكتور أحمد. ازيك ان شاء الله. وحشني والله. وحشني. Long time I didn't see. No, he is my mentor.
And thank you all for coming, and I'm sure it will be time well spent. I know it's your weekend, but I'm sure it's going to be worth it, and we look forward to having more events such as this.
Inshallah,
Ahmed,
inshallah.
Keep up the good work.
By new leaders, huh? I told you from the start, we will build the new leaders for the coming activities, inshallah. Not me alone, as a team.
We expect to be very busy this season and the coming seasons. Ahmed, I interrupted your presentation, but
no, you are on time of the break, first break.
Great, thank you. So I could talk with everyone one-on-one. Thank you.
Before the break, Dr. Adnan need to run very quickly. He will need to hit me. I need to ask you before you go. Did you take some points? You fix. I know that you. What is the most important point you get? Simple. He feels that all the information is very basic, and me, I give my importance to basic because of what I know. Many may be working, but they don't have the base. By at the end of the day, you will know. If you understand the name of the artifact, how it comes during work, you can overcome this artifact. But not keeping like this. This is artifact. Why like that? Why like that? You should know why. If you know why, you can overcome. Let us to take the break, and then we will continue our day. صباح how many chicken? You need مفتح. بيسموه مفتح هنا ولا ايه؟ going to the core. But quickly you should know the new updates in ultrasound to help you, and some points I will jump it quickly. Let us to start. You are ready now? Light? Light? التشيكنج جاهزة؟ ها؟ يارا؟ طيب. This is considered a basic lecture. I will not go through the time of that because we have many items I should cover, but quickly, to build some knowledge inside your mind and deliver this knowledge to your hand. Because ultrasound, mind, eye, hand, pathology, real time, patient problem, that you are managing something you should control. So that let us to understand some points quickly regarding the basic physics of ultrasound. We know that ultrasound is dolphin.
Many of the sounds they make are above
interact
the range
with
of human hearing.
Ultrasound. This is fact.
Signals.
The most important point in ultrasound machine is that area inside the probe, which is ceramic material change electricity into ultrasound, and then to give ultrasound change into electricity. Simply. Then this is a way to get an image.
Every time this ultrasound enters or leaves organs and tissues inside the body, some of it is reflected back as an echo. By picking up and analyzing these echoes, a diagnostic ultrasound system can build up an image of these organs and tissues.
Okay, this is the way quickly how the image is come.
Detail.
And what's happening is there are many new technologies in ultrasound.
By using semiconductor
Let me
processing
to jump to the
techniques
most important point. Remember that this nowadays ultrasound started like that. It was like this. The ultrasound machine, the patient stand like that. It was 1957. Then what happened? Becomes the computerized little bit. Then what happened? Give image like that. The image becomes more better. This is 1970 and this is 80s. In 1980, 90, like this, real time. Then 3D, then 4D, then 5D. Can I ask one question? It is not your for radiologists. What is the difference between 2D and the 3D ultrasound? 2D ultrasound is the image like that, height and width. 3D, height, width, and depth. What is 4D? Means what? Today I need to make you understand. You know it's time. Give me the explanation. Like this. Look to me. You are looking to me. I am now, my face, my head is height, width, and depth. It is what? If I make like that, the moving 3D is the 4D. Okay? What else? What is 5D? Some machines, some companies make to visualize that at least 20% from this side, from this side, from this side. It is like that. What is 9D? 9D, it is in cinema. You will sit and some water, some like that. Up to 5D, we do it in ultrasound. Okay? Okay, what is? This is 1946 machine. Start like that, the image. Then machine developed like this. Upgraded to be small, portable. Then like that. Then like this with wire. After this, it becomes smaller. Now it's wire also, but what's happening today? Like what? Like that. It is on the phone, handheld, wireless probe, and this is the near future. It will not be far future. Its name, ultrasound nowadays, Its name is what? It is the stethoscope of doctor. Every professional in healthcare will have in the near future will have ultrasound. So that nowadays ultrasound, some of you told me that he has fast. He know how to do fast. All surgeons, they should know how to do fast. You are in the clinic and you see one patient came dropped by simple points. What you should do? You see internal hemorrhage or not quickly. Even the nurse in ER. So that ultrasound nowadays, ultrasound training is required all over the globe. Okay, this is the updates, and you know that there is an endoscopic ultrasound. It is the future and the technology. So that while we are using, we are need to know what is ultrasound. It is a wave like this, baby. The sound is, we know the wave like that. Ultrasound wave, if it runs in any tissue, like the wave of the water in the sea. The water itself is in its place. It is not moving. The moving is the wave. Like this line. Look to this. The letters are in the same place, but the wave is running. Wave is an energy. Okay? So that we will not hear the ultrasound because of the frequency like this. The ultrasound is a wave like that, running in time. It has height and the time and the repetition. This wave, I can repeat it in the second 5 times. Means what? Frequency 5 times per second. This is an example. If it is 1000 per second, 2000 per second, all probes of ultrasound working by, I will tell you, just to put it in your mind, okay? This is the very great or simple pace of ultrasound. Electricity coming to hit the piezoelectric effect, the crystal, to translate it into ultrasound beam, hit the organ, go back to the machine here, which is computer. At the end, electricity going, electricity coming. Difference in type of electricity coming according to the difference in tissues here will give you grayness scale. So that we name it gray scale. You will see scale on the side of the image. Its name, we name this ultrasound, it is gray scale ultrasound. Or brightness mode ultrasound, درجات الbrightness, degree of brightness. Or real time ultrasound. Or 2D ultrasound. All of these are the name of the images used in your injections. Okay? And the computer analyze the returning electricity. This is a simple base, just to beat in your mind. Into bright and dots gray and dots black. According to what? If this area is a bone, the reflected echoes will be very, very, very large. These very large echoes will give me, take it simple, take it simple. I'm not physicist. Very large electricity. It will be more brighter. If this is water, no reflection, no electricity, it will be dark. So that the water is greatly dark. We name it sonolucent. The bone is greatly brighter or hyper-echoic or like water anechoic. Sonolucent. Brighter means echo-dense, like that. These some names, you can read it in a ultrasound probes. We know that we have high frequency probe and the low frequency probe. High frequency means I repeat the frequency more in the same second. But this is low frequency, means I repeat it low number. We name it by another mean, like this. This is linear probe, like this one. This is a linear probe. This is linear probe. We name it superficial probe, high frequency probe. Energy outcoming from this probe is higher. So that we use it in pregnancy, in endocavitary, don't use it more. Okay? In early pregnancy. But this just a knowledge. This is named superficial probe, linear probe, high frequency probe. When you increase the frequency, you will work superficial. When you make it low frequency, you will go deeper. So that this is named deep probe, curvilinear probe. When you put the image, you can use it. When you use it in injection, usually we use that. And this is footprint. Frequency is high. These are high frequency. Their resolution will be very good. This resolution is good also, but not like that. But the depth here, you will work about 35 centimeter, no more. The same. This you can go to up to 30 centimeter, 35 centimeter. You can see the kidney, you can see like that. Sometimes you need to inject the hip joint. The hip joint is deep, and the patient is obese like that. You will use this. And while using this, remember what? The base I told you. This is the needle, and this is a probe here in the hip joint. I will go like this in plane, for example. Look, in plane like that. This beam not like the other. Beam is divergent, so that the returning echoes will not come to this. What I should do? I should do like this. These are basics. If you don't know that, you will work like that. If you have the base, you can be confident, accurate, and as reasonable. Okay? Let us go back to the type of probes. This is high frequency, maybe footprint, maybe. Frequencies, the low frequency is from 1 to up till 5 megahertz. The higher frequencies from 7, 8, 12, 14, 16, 18, 20, sometimes more than 20. Means what? I will work on the skin. This is the new era. Nowadays you are training some doctors in aesthetic medicine on the skin, dermatologic ultrasound, to see the layers of the skin. By what? Very high frequencies. Here, the image here is very good, and the resolution, this is the curve. And what is that? Just to have an idea. This is for echo. It is small like this, to see in between ribs. It is like that, okay? We will not use that in injection, but remember that the air is the enemy of ultrasound. But nowadays, I told you, we use the artifact of air in lung ultrasound, so that if there is air, what is the value of gel? We put the gel not for lubrication. The second benefit is lubrication, but the first benefit is to remove the air between the probe and the skin, because any air inside, khalas, you will not see. So that during work in injection, regarding the quality and the safety and the infection control, you should cover the air. You should cover the probe. You should cover the probe. If you put the cover and there is air inside the cover, you will not see the image. Okay. Ultrasound is divided into Doppler, without Doppler. Ultrasound A mode, M mode, B mode. We are working in B mode, which is 2D, which is brightness mode. B means brightness. Okay? M mode, this is another thing, and the Doppler like zero angle. Just for information, because you may use Doppler during injection, so that you should know the color, red and the blue. What is red? What is blue? Red not artery, blue not vein. Yes, it is directions. If you see red and the blue, it is if the fluid is going toward the probe, it will take red. If the fluid or the blood going away from the probe, it will take what? Blue. And you can invert. But remember that if you need to see the vessel very well, by Doppler, never to be 90 degrees. It's the opposite exactly, rather than the B mode. You should make like this. Okay? And this is another issue for radiologists, inshallah. If you need Doppler, very good Doppler basics, inshallah, we can deliver it to you. Here, A mode. A mode means what? The returning wave, we will use the amplitude, amplitude of the wave, and we can take what? We can take image like this. This is used in ophthalmology. Okay? This is 2D, B mode. This is M mode. And the Doppler give us direction and the velocity. You know, في ساهر اسمه هنا ولا اسمه ايه بتاع الرادار العربيات اللي هو check the speed on the highway. It is radar. Radar means Doppler. It runs by the basics of Doppler. Detect what? Direction and the velocity of a moving object. What is moving inside the body is blood. If you see this is red, look to that map. Red is up, means that this is going toward this line, toward the blue. And look to this green, red, blue. This blue means what? It is going from here, going deep. From here, go this direction. What are the velocities? Look to this yellow one. This is faster than this. Okay? At the end, Doppler give us what in ultrasound? Give us two things: direction and the velocity of the moving RBCs. By this, we can take a decision about what? About the disease of stenosis of occlusion. For you as an orthopedics or need to inject, sometimes you should use color box to check this is a nerve or vein or an artery. You should avoid that before, or sometimes you may use it in musculoskeletal to check the vascularity of the lesion. Arteritis, abscess, you see hyperemia, you should apply the color. So that I give you a hint about Doppler. And at the end, red and the blue, not artery and vein. I can adjust on artery and vein, but it is direction and velocity rather than artery and vein. And fundamentals, it is خلاص يعني we need to jump. Look to this machine. This is 2D or 1D. D1 means Doppler, but this 2D is what? 2 dimension. It is B mode. It is real time. It is grayscale, black and white ultrasound. It is ours, okay? Just to have an idea. This is continuous wave Doppler, power Doppler, 3D, 4D. Other things. This is a very important button named freeze to let the machine working or not. Freeze, okay? Image orientation. Let us to do this on the machine is better. Some guidelines for injection. It is very important, and I will deliver this to you in your may develop recorded like that. This will make you more professional, will help you, will save you, will make you more upgrading yourself. By time you can review what else, you will make you one of the new leaders to train with us, because this material will help you in everything. So that documentation is very good, important in quality. Safety considerations, all of these are very important. I will send it to you. Let us jump to the very important lecture, and after that lecture we'll jump to the الساعة كام دلوقتي؟ 11 كويس. إن شاء الله we will be on time. This is our main lecture today, but before I go, I should do some things. I should entertain what we are doing. Ahmed, احنا هننتقل على التشيكن just to do some things. Gloves, please. نعم عارفين ان احنا كلنا we did not take the lunch, but don't think that this is lunch. Huh? Thank you. I will highlight on some points before we go to that session. اقلع جاكيت. انا احييك. شكرا دكتور. طيب خليني بس عشان ان شاء الله هقلعه دلوقتي عشان احنا هنشتغل دلوقتي، كلنا هنشتغل بس not now. وصل لي مش شغال. الدكتورة شيماء. ايوه very good. To see. Okay, this is another level. Here in this chicken, without doing what Dr. Adnan, he told me to put inside a glove some gel, and I put it inside to see a cyst. This is good. But me, today, I need to give you the joints. Where is it? There are many joints here. Let us to see. إن شاء الله وهنخليك تجرب دي. وأنا على فكرة جايبها عشان أنت تشتغل معايا. أوكي. الجل دافي كويس ها، وده دافعين الجل ده كويس، يعني مكنه فيها حاجه بتدفي الجل، وده ما عادش حد بيجيب مكنه لما يجيب فيها المدفئ ده، اللي بيعمل مشكله للمريض لما تيجي تحقنه او تيجي ايه، بيحس انه ساقع قوي عليه. وان كنت احيانا بتحب البرد دوت عشان ايه تخليه. When I use the gloves, this is me. All over the time, when I wear a glove, I should make like this. Don't ask me why. I don't know. This is allergy, what is name, and this is written in the box. Okay. Yes, but it has no powder. Well, okay. It is sensitive. Can you give me a needle, يا needle? needle. واحدة بس. needle واحدة بس. هون أي واحدة. This is the image. I will make it brighter. Brighter and darker means gain. We name it gain. Where there is 2D button here. Its name is 2D. I will make it more brighter. I need you to concentrate with me on some basics. I give it to you. Look to this brighter point. When I make angulation by the tilting by the probe, where is it? When I make it 90 degree, you see it is very well. It appears very well. The same will happen to the tissues. Look to these tissues. Look to the fibers. When you make angulation, the fibers are lost. When you make it 90 degree, the fibers will be more accurate, more resolution. Okay. If you need to inject a thyroid, it is typical like thyroid. You can use this to train yourself, your hand. What I need to do, انت جبت لي ابره يا يس ثانك يو مريم، معلش اوعي ايديكي بس. تسلم ايديكي. دكتور عدنان بعد اذنك اتفضل. wear gloves. Just a test, The basics of ultrasound image, very important. Very important. Before any injection to do, we will explain this in the second session, but just now to highlight on some points. Dr. Adnan, actually I appreciate his effort from the start of the day. He told me he is, alhamdulillah, expert and he can do many things. And I appreciate that because we are a team. The next time, inshallah, he will be with me in the training discourse. Okay, catch this. Okay, hold this. I need you to show, no, catch the group also. Okay. Inject and show me the needle. What he did, just a moment. He put his 2 fingers to fix the needle. This is very important. Putting 2 fingers to fix. Then he make in plane. He is looking, before looking here, he is looking to put the line of the needle inside the plane of the probe. Now you see the needle. Where is the needle? Yalla, go. The needle is here. You can see the tip. These are multiple lines, means what? Reverberation. Where is the tip? You hit the bone. Yes. You can go away. Okay. I need you to come here. Okay. What he did, he make angulation. Okay. Let us to be outside. Just what I will do. The same doctor, the same hand, he will do the same thing now. Yalla. Again. What will happen? He is going from this. He is doing the same. What will happen now? We are looking here. Look, where is the needle? Where is the needle? Coming from the other side. Catastrophe. Because of that, I make this day. To orient the machine very well, then to start the injection. Why? Why the needle is coming from here? Probe mark. Rotation. So, any probe has mark. Before you start, you should know the mark. Where is the mark? In the image here, this is the mark. Okay? Should be with the mark here. So that you need to cut this tissue. You will cut it transverse. The thumb with this probe, the thumb with the mark. You know from your mind the thumb is with the mark. That means that this is the side of the thumb. You will put here, the needle is the other side. Okay? This is the orientation. I need all of you today to build the orientation of image with the needle on the chicken after in the hands on. Okay? هتعمل ايه يا دكتورنا؟ هيشيل دي. Now the lesion is accessible to this side. What I should do? I can make the needle toward to see it, to make a mark, or I can do the opposite. This orientation is very. انت فاهمني ولا؟ this one of the basics today. You should all of you to because if you are working in ultrasound and you don't know, this is problem. Okay. What else? Look to this one without seeing the needle. Me, I did not see the image, but from here, now you can see the needle. Needle appear or not? Yes, I did not see the image, but I am sure. Why? Because I put this line of the needle with this line of the plane of the image. This, the first step. Then jump to the image. If you don't know this, you will not get an image, good image. So that after doing this in plane, you know now in plane, all of you, 100% of you should know the in-plane technique. Okay? This is in-plane technique. You see the needle. دكتور معلش اتفضل امسك عشان انا حابب اشتغل وانا اشرح. Now he fixed the probe. He fixed the plane of image. What we need, this is the line at the side of the joint, for example. And I need to give the tip to that area. Okay, he is not seeing the tip. Don't go through until you see and then go. Okay? What happened? What happened? It is not in plane. It is just outside like that. This will, if you don't do this practice, you will not get confident injection in the joint. Now he can see in plane. Okay. Show me out of plane. Yes. Remove the needle. I'll go out of plane to this region. How to bring this region in the image? Before you go, I will put that point in the center of the probe. In the center of the probe. This is the wide of the center. From here, this is a probe. From here to here. When I put it like that, in the center, so that you see, there is a mark. Put the mark, try to make it in the center. And then go with the needle directly. Look to this. Now, where is the tip? You see the tip? No. You see the tip? طب ثانية يا دكتور معلش. No. Where is the tip? It is nearby the tip, not the tip exactly. Okay? Look to this. I will go in plane, out of plane. Okay? Where is the tip? You see something moving, You see it? Did you see? No. Okay. I will like this. You see? But if I make it nearby like that, you see? I'm trying, but I cannot see the bevel exactly. Okay? You will use this out of plane in some situation, especially in superficial joints, in very superficial, like thyroid, Dr. Ash'a. If you need to take thyroid, it is sometimes if you go in plane, you will hit the carotid, so that you should go like that. It is some points to refresh you. I know the next session will be theoretical more. عشان كده حبيت اعمل لكم interactivity to be interactive to refresh. يلا كده 5 3 2 minutes 2 minutes only. Refresh your mind because the next lecture will be strong. Okay, I need your concentration. Thank you دكتورنا. Thank you. We'll do again إن شاء الله. ما تسيبش, don't leave the probe open. If the probe will extend, durability will be 10 years. If you leave it, it will be 5 years. Freeze, usually freeze, huh? Now I'm happy because there is a question. Okay.
Usually I'm using the ultrasound to detect the during caudal epidural injection.
Caudal?
Yeah,
Yes.
caudal epidural injection. I'm using the ultrasound to detect exactly the area where I have to go. But can I also do the injection under ultrasound guidance? Yeah. Usually I'm detect the area, then with my finger palpation.
Because
I'm
you know
going
the
to-
surface anatomy.
Yes.
By this way, you can, if you are accurate about 70%, by ultrasound you will need by 90%.
Okay.
It is better.
Mm.
Sure, to know the location, to apply ultrasound, to know the bone, and the relation of the muscles, and like that, it will be great. It will help you so much.
Mhm.
المايك الثاني خلاص؟ راح فين؟ بنصه على راسي. استخدم ده. اوكي. توكل على الله. هلا يا دكتورة. خلينا كده ايه احرار بقى. This lecture actually it is I spend a lot of time to make it simple as but usually videos make the information fixed more than written words. We can change the projector يا أحمد. هننقل صورة الجهاز بس. When I was in the time of preparing the session, the subject is long. Each joint need 1 day to explain the anatomy, to explain the directions, but how to summarize, actually it takes a lot of effort, so that I will use some your experience and my experience, and we will correlate many things with each other to make it simple inshallah. Already I am a professor in Al-Azhar University, Faculty of Medicine, in Cairo, Egypt. This is my main job and career. And 12 years ago, I started to change a little bit the career to the way of training, because I found a great benefit for the generation, so that I know many of my students, of my colleagues, like Heba, like Ala, like Dr. Farouk, like. Why? Because I transferred from country to country to country. I put the training, it takes my heart. Because I found that I have a great impact in my community. And this is my main rule. If you get a community social responsibility, this will give you great benefit, and you will feel this, and this feeling never to be compensated by any money, by anything. I know all of us, we like money, but the benefits is to know doctors from Sudan, doctors from Iran, from India, from, and you see the benefits going to the people, all people. This is our main mission as a doctors, and you are better than me, but me alone, not good. You alone, not good. We should be a team, like we said before, in the first of the day, and start of the day. Ultrasound guided injections. Before I go through it, I thank so much Meridian Healthcare Academy, actually, and I thank all of the team, starting from all of the team. I will not describe anyone. Thank you all. Thank you all. Thank you all so much, because you exerted a lot of effort to make this environment, to make this situation suitable for the attendees. And I thank Mom Dr. Ahmed. شكرا دكتورة على تشريفك معانا، وربنا يديك الصحة وإن شاء الله في كل كورس تكوني معانا كده أهو. Let us to start to this lecture. الساعة كام دلوقتي معاكم؟ بعد 10. حلو قوي. في حاجات في some slides I will jump quickly and some slides I will stop. But let us to know what is the difference between injecting without guidance and injecting with guidance. This is a step we should know it. Non-guidance injection. Look what happened. And you are orthopedic surgeons, you know this. But let us to see this video quickly. This doctor need to do injection. He know the surface anatomy, and I ask you what he will inject. Okay, you know. دكتور هيحقن ايه؟ هيحقن ايه؟ Subacromial space. You know this. You know, okay? But he will directly now put the needle according to surface anatomy. How much accuracy percent? Huh? There is some doubt. So, yes, like that. So that look to this way of injection. Now, while using ultrasound guidance, the precision of the injection is more accurate. Look to this needle. I need to inject the space in front of the joint here. And I'm waiting this fluid to maximize the size of of this area, okay? So that I see the tip, I see the needle, I am more accurate, ensuring medication is delivered to the target area very well with minimal risk of injury, okay? All of these are values of using ultrasound. You will not hit a nerve or blood vessel, or you cannot destroy a tendon by seeing that. So that this lecture, I will go through the upper limb injection of the shoulder, elbow, wrist, and hand, and step by step we will see where we will go, inshallah. Shoulder joint, one of the joints is very important, commonly used for both injection. We use it for both, for diagnosis and sometimes in MRI. مين كان هنا بيشتغل MRI وقال لي كان في دكتور قال لي انه يشتغل MRI؟ مشي. يعني بيجي يحقن في حاجه اسمها upper position، يملى لي الجوينت fluid to see the joint very well, or sometimes arthrography. This is sometimes diagnostic, but therapeutic we use it. Ultrasound on surface anatomy, this will make the orthopedic surgeon better than radiologist because he has the clinical sense and he knows the surface anatomy. But the imagination of image at the radiology is better, so that combination is very accurate. Indication for the procedures, we know all of these. I think I will not go through it, but mainly arthritis, adhesive capsulitis, rotator cuff injuries, subacromial bursitis, whatever, you know all of these. Sometimes we use injection of the shoulder for diagnostic procedures. Look to this introductory video for the shoulder injection. We will explain some points.
The shoulder is prone to different kinds of injuries and inflammatory conditions. An intra-articular shoulder injection is a minimally invasive procedure to treat pain and improve shoulder movement. It may be performed with the help of ultrasound or fluoroscopic imaging, which allows your physician to precisely target the intra-articular space. Anatomy. The shoulder consists of two joints. The main joint is the glenohumeral joint, formed by the head of the
وده اللي هنروح نشوفه بيتحقن ازاي. يبقى حقن الglenohumeral joint, one of the points.
upper arm bone or humerus, and the glenoid cavity at the side of the shoulder blade. The acromioclavicular joint of the shoulder is formed by the
وده بيتحقن بنديله injection. مظبوط يا دكاترة ولا؟
clavicle or collarbone, and the acromion, a bony projection of the shoulder blade. The shoulder is supported by muscles, tendons, and ligaments. The rotator cuff is a group of 4 muscles that provide stability to the shoulder and enable arm movements in various directions. A fluid-filled sac called a bursa is present between
ودي بنحقنها. سؤال ممكن؟ Can I ask a question? Why you inject بيرزا؟ يلا دكاترة الأورثوبيديك. Inflammatory. Sometimes while you are using to see the Berza by ultrasound, you may use color to check the hypervascularity, to know where is the artery, where is the area. You should avoid that area. Okay? So that knowing the anatomy very well and knowing the direction of injection
Clean the muscles and
is very
bones
important.
to provide lubrication for smooth shoulder movements. Intra-articular shoulder injections are used for diagnostic as well as therapeutic purposes. Corticosteroids and hyaluronic acid are the most commonly injected medications to relieve pain and inflammation or improve lubrication in the joint. Indications. Some of the common indications for intra-articular shoulder injections include arthritis, frozen shoulder, rotator cuff injuries, impingement syndrome, tendinitis, ligament injuries, and bursitis. Your doctor will recommend a joint injection if your symptoms are not relieved by conservative treatments such as oral medications, activity modification, and physical therapy. Surgical procedure. The administration of the injection depends upon the condition to be treated. Your doctor may inject the glenohumeral joint or the acromioclavicular
These are the major points or major sites of injection, okay?
joint. The glenohumeral joint is usually approached from the front or back of the shoulder.
Two approaches.
During an
Posterior and
ultrasound-guided intra-articular shoulder injection, you will be asked to lie or sit down depending on the site of the injection.
Regarding the position of the patient, you will see in the YouTube, you will see your experience, your own experience. Sometimes you sit with a comfortable position. Like now, I did like that, I go here. But the major idea is to be comfortable during combining the image and the needle tip. And again, the needle tip. This is the target. You sit like this, you sit like this. You will see many doctors in the YouTube or in clinics, they may be different. Don't worry. Try to invent a way. يعني انت شايف حضرتك مكان تقدر تعمل حاجة كويس، اعملها وسجلها. Never to neglect or never to underestimate what you have from experience. Daily work, you will get your own experience. If you repeat this daily work 100 times, you can write it in a paper. Research work. So that never to neglect or never underestimate what you have from the raw materials coming to you. Upgrade, put this in your mind, you can do. Okay?
A clear water-based conducting gel is applied over the skin.
What is the major function of gel? Can you tell me? Remove the air. Secondly, it is lubrication.
To assist with transmission of the sound waves. Your doctor moves a handheld probe called a transducer over the targeted area. The transducer emits sound waves and detects the rebound echoes from the tissue. Images are created from these sound waves and can be viewed on a display monitor. This provides a clear view of the targeted area and helps your doctor guide the needle to the correct site for the injection. Alternatively, your doctor may use fluoroscopy or...
Did you do any fluoroscopy? Anyone? Yes. Is it accurate? Accurate. But sometimes, if you use ultrasound, you will get more accuracy. Because you see, here you see only the bone and you know surface anatomy like this, and on and. But in ultrasound, you see the whole of the structures.
Live X-ray to guide the injection to the correct location. Post-operative care. After receiving the injection,
Pre-operative care and post-operative care, this is quality في guidelines. You should keep on infection control. And I appreciate Dr. Adnan while he told me where is the glove before he start. And I will show you image now and make it cross over it, because many of the doctors, even radiologists, use the probe without covering the probe. And this is, I consider it is a crime. Don't do any injection without covering the probe. because the probe of ultrasound is used upon hundreds and thousands of patients, and it will not be completely disinfected. So that disinfection is important. To cover the probe, it is mandatory. Never to do any injection without covering a probe. And I will show you some.
You will remain in the supine or seated position for a few minutes. The joint is put through passive strenuous
all of
activity
you
which
know
can
that.
be treated.
Let us to jump to the second one. Shoulder joint injected in subacromial bursa, glenohumeral joint, anterior and posterior approach, acromioclavicular joint, long head of biceps tendon is injected. This is the bursa, and we know
Here's
the anatomy of the bursa.
Look with peribursal fat around it. You see how thin it is, and it just kind of laces over.
Look to the bursa here. Here is the head. The bursa here, it is not seen. You know the anatomy here, subcutaneous tissue, deltoid muscle, and this is bone, and the bursa is at that point. To be accurate, you should put the needle tip inside that region, and you should know the bevel. Is it upwards or downward? It is superficial, it is directed like this or like this. Sometimes you inject here, and when you come to inject, the fluid is not coming inside the bursa. Why? Because the bevel is directed outside. So that look to this video. Here you are accurate, and here, where is the tip? Tip is not here. There is an artifact, it's called cross-cut artifact. I told you this from this last session. If you put the probe like that, I see all the shaft. Okay? If I put the probe like this, some tilt, some very tilt, you will see part of the shaft, but you cannot see the tip. This is what's happening here. But you know the tip by what? By indirect way here. You see movement of the fluid or air inside the area of injection. Look to this area. You see the movement is here. That means that the tip reaching good to the side. Look to the expansion of the bursa. What is happening? The bursa is expanded. That means you are accurate. If you are not in the bursa, the fluid will be restricted in this tissue or in this tissue. So that expansion is an indicator that you are in a good targeted area. Okay? This is subacromial bursa injection. The way and this will need, I think, more and more. So, this is a explanation on a patient. He put the major artifact, the major crime. I consider it a crime. Look to the probe. It's not covered. Never to take this from videos and do like that. Cover the probe. Very important. So that here, this way is in plane. This way is in plane. Look to this mark. This mark is here on the image, the yellowish one. And this mark is here. That means that the needle is going from this side. And then he see the tip. He started to inject the A. Look to the fluid is playing inside the bursal space. And these are artifacts. You see here the artifact? Artifact of, look to this. Sometimes you may see this artifact alone. Look to this one. This is the needle. 1, 2, 3, 4, 5, 5. All of these are reverberation artifact. What is wrong here? Using the probe without cover. Please don't put this in your mind. All of these words, it is you can read it, inshallah. This lecture will be with you. Don't worry. خلاص. Subacromial bursa, again the same video. خلاص. We see the tip, the needle of the tip. We adjust the needle here. At that region, I will start, when I reach it, I will start to inject, and then when you see the bursa is distended, that means you are in a good, accurate place. Glenohumeral joint injection posterior approach is commonly used for injection. Here the needle is like that. Let us to go to some tips. My main target of the day is not to go through the anatomy and I'm going to fix the core slide I show it to you. So that how do you know you are in a joint? Question. The capsule will lift up as you inject. كل ما تحن, when you inject slowly, you will see capsule.
This is indicator. The injectate will flow away from the needle tip. You will see it away from the needle tip. Accumulation of fluid in the area suggests extra. If there is a loculation of the fluid around, it means it is outside. The pressure in the syringe will be. These tips or skills you will not give, we will not take it until you make more practice on this check. At the end, the injection will see like flash. We will see this. Look to this glenohumeral joint injection. And I appreciate all those people working and giving us these illustrative videos, and I thank them so much. So that my advice to you, if you need to maximize your benefit,
the first thing to
from
do
God,
whenever you're carrying
before
out an
money,
ultrasound-guided injection,
try to collect and document and archive your data day by day by day. You will use this to help your colleagues.
is to get
What happened? This doctor, what happened from the start?
The first thing to do whenever you're carrying out an ultrasound-guided injection is
look to the probe is covered. Second, he is wearing a apron. Then he is wearing a gloves. He will do something to know the mark of the probe. He will put his finger like this. I don't appreciate that. Don't put the finger at any area disinfected. Even your finger is covered by sterile. Because you are understanding the orientation, I will explain this on the machine. You know where is the mark. You may make more pressure. You may move the probe. You will know the mark. But don't do like this. This is a quick. I know sometimes you are in doubt and it is confused. Put it, alas. But put it, remember, don't remove the disinfection. Sterilization is very important.
To get a really nice, clear image. Now, a simple way of finding the right position is to find the posterior aspect of the acromion and just place the probe just underneath the acromion.
Look to the resolution of the image. This is difference in machines and the difference in frequencies. If there is high frequency, you will see more better. If there is low frequency, you will not see more better. This is a posterior approach of the glenohumeral ligament.
It's important to know which side is which, so you can see the top of this is...
What is that area of blackness? This is an artifact, because the probe is not touching all of the surface. The surface is like this, so that the probe, I should move the probe like this or like this, to make it in contact, to remove this area.
On the right side, so I'm actually going to spin that round, because I'd prefer that to be on the...
Look what he did. He did here. Look to his finger.
So I'm actually going to
again
is which, so you can see the...
He put the finger on that area of the probe to check is it moving here or not, to know the direction of the probe.
Top of this is on the right side, so I'm actually going to spin that round, because I'd prefer that to be on the left side. Now, if we look at the image, what we can see here is the skin, subcutaneous tissue, deltoid, and
this is anatomical,
clearly, which is a nice landmark to find. You can see the humeral head, which is obviously nice and round and bright, and you can see the articular cartilage on top of there. If we slide...
Articular cartilage, it is the black line. The bright line is bone, covered by articular cartilage, the black line, okay?
Further around to the back, you can quite nicely now see the glenoid. Now, I would recommend at this point, even on top-end machines, that you reduce your frequency. I'm down to 10.
Remember that this is a glenoid, and this is the joint, and here there should be labrum, okay? Don't hit the labrum by needle if you like to go to the joint. This will not come unless you will be confident, accurate to see the needle tip.
Megahertz, and you can see...
سؤال. It is possible if you are not accurate. If you know this and you test your hand, if the needle go to the cartilage, it will make destroy. So that keep on Keep on seeing the needle bevel. It is not. She is not saying to go through. She is not. She is saying it is hitting the surface of it. Okay, so that if hit more than one time, you will make injury. So that if I go before it, I will be accurate. So that my day is going to make you accurate in seeing the needle tip, not seeing only. What is meant by seeing? To deliver to you the orientation between the hand, the eye, and the probe and the image. This is a step of intervention. If you don't know this on scientific base, all over your life, you will be hitting many things, and this will not. No one will know unless there is hitting something dangerous. And I saw this. I saw this many times. So that I exert a lot of effort to fix in your mind the basics and the safety.
That's given me a really nice image. It is important just to highlight, and you can see.
Look to this one. While doing the examination, and if you are coming from here, you see the needle. If you are coming by your needle from this side, and you are not seeing the tip very well, you need to be directed here. Sometimes you don't know. Starting, you may hit this pulsating structure, which is an artery.
There, and you can obviously put your Doppler on, and you should be able to see a small vessel. Now, it is a long way from the target, but it's important to identify that. And if your needle angle is too shallow, then you may find that you do start encroaching this area here. Now, this is the spinoglenoid notch, and you can see that there's going to be an artery and a nerve. So we need to avoid that. The target is obviously between the glenoid and the humerus. So let's just go through. We've got the deltoid, we've got the infraspinatus muscle belly, and through the middle there you can see the
my question for you as surgeon and know the anatomy, why this is infraspinatus, not supraspinatus? Because you are posterior approach, and you are under the spinous process. Combining the anatomy, surface anatomy, and the image orientation and the control, you will be higher in your accuracy than me as a radiologist if I don't understand the anatomy like you.
Now it's not sterile. For me now it's not sterile.
Yes, yes,
the
yes.
It's not sterile.
Yes, yes.
Is this correct?
No.
Okay.
No at all. We jumped here. I'm highlighting on some points. Sterilization is mandatory. Covering the probe is mandatory. Your gloves are sterile is mandatory. Your environment, and this is in the guidelines. Lecture in the guidelines you can see. I will put it in the group because I like to concentrate on the area of importance.
Spinatus tendon. Now, when I first started injecting,
look to
I was
the tendon.
Always cautious about
just an ultrasound point of view. Tendon is like that, brighter and the lines inside, but look to the muscles, little bit darker, okay? But it is not what? It is not sonolucent. It is not clear like fluid. It's a tissue is, my question, why it is darker than tendon? Question, أشعة. More water content than tendon, okay? By this way, think in the image of ultrasound.
Putting the needle through the tendon, because I thought it might be a bit more sore. I do try and avoid it still, but certainly it's nothing you need to be too concerned about. You can pass a needle through that tendon, and it doesn't seem to cause any extra pain. You can see the labrum sitting on top of the glenoid, and the target area is here. Now, this is the posterior joint recess in here, and this is where we're going to be targeting our needle placement. So just coming from the top left region here all the way down into the region there which you can see, which is the posterior joint recess.
To have an orientation from the site of entrance of the probe, entrance of the needle, to the point of to the target point, it is very important. And we can build this, inshallah, in the work on chicken. Glenohumeral joint anterior approach like that, using the also in-plane method, like this. I will not go through, but here I'll jump to the acromioclavicular joint. Look to this plane of the probe. It is lying longitudinal along the bones. You see the joint here like this, okay? And he will start to do the injection. What he did, there is no cover, okay? Please don't do that. Look to what else. Second point I need to highlight upon it. From the start of injection, from the start of putting the needle into the skin, I should see the needle at this 1 centimeter. If I cannot see, don't go through more. Stop, adjust your hand, adjust your image of the target area, and adjust the in-plane technique. He is trying to adjust the probe with the needle, so that, did you see the needle? For you. ما شفتوش النيدل اهو، النيدل هنا اهو. Okay? But the wrong thing is now he inject inside the joint exactly, and he see the fluid expanding the joint, and but one more point for orientation. Look to here. You are looking to the needle coming from this side, thinking that the needle coming from here. Huh? No, it comes from here because the probe is inverted. Like we did. We will show this in practical session. I think this is in Sharjah, صح? Did you see it? رحتها؟ فعلا في هناك كافيه فيها ولا ايه؟ قاسمية ها؟ Great Sharjah إن شاء الله. It is good, but the weather is so much حلوة. Elbow joint. We know the anatomy of elbow joint. Review the anatomy usually is good to know that some points to combine it with the use of injection.
It is easy to see why.
But let us to go to the important points in our lecture. Look to this probe now. It is aligned longitudinal. Aligned longitudinal with the area of injection. So that here is a bone and here is a bone. But I will ask you, this is the lateral or medial end of the elbow? Lateral. Means he is going to inject what? Tenosynovitis. Its name, other name is? Tennis elbow. Okay? Elbow injection, joint injection can be diagnostic or therapeutic. Okay? But remember, don't inject the steroids into the tendon itself. If you see any tendon, don't put the steroids inside the tendon, because it may have some complications. And this is a common indication for elbow injection: tennis elbow, golfer's elbow, medial epicondylitis, lateral epicondylitis. All of these are indications, and this diagnostic purposes sometimes we use it. What are the areas should be injected in the elbow, or commonly injected or usually injected? Radiocapitellar, tennis elbow, golfer's. I choose some common areas. If you see some areas common more, tell me, okay? Because you are orthopedic surgeon. Here, again, this is in plane or out of plane? Okay, if you see this mark, that means if you look to the image of ultrasound, you will see the needle coming from the side of the mark. Okay? If the mark is opposite, you will look to the needle coming from the other side of the mark. Okay? A stiff, swollen, painful joint, usually clinical indication. Look to this osteoarthritis or rheumatoid arthritis, and this is sometimes crystal-induced arthritis. And this, one of the positions, to put the patient like that, and put it also longitudinal, lateral to the lateral epicondyle.
This longitudinal approach will show you the image like this. Bone and the bone. Lateral side, and this is the joint area. Here is also lateral. Sometimes we may need to use the out of plane method. You may need to use, remember the basics I give it to you. If you use out of plane, you will be, as you can, try to adjust the needle with the probe to get more visualization of more portion of the distal end of the tip of the needle. Like that, you see the needle like this in the lateral view. And here also is the out of plane method. Forget the needle. Concentrate with me. Forget the needle. Again, review the anatomy. It is put, the probe is put longitudinal. The mark is down. Means what will appear in relation to the mark as anatomy? Radial. Okay? Then he will decide to go out of plane. Out of plane, not coming from here or coming from here. Out of plane coming directly like this. Okay? You will see this tip of the needle here. It is not exactly the tip. So that you will depend upon the indirect signs of seeing the tip location. What are indirect signs? Sometimes movement of the tissues. Sometimes the fluid injected. You see the fluid around. Doing something like that. All of these points will make you more professional in your work. This is out of plane technique. The same also, you will see the needle is as a point. You will not see it longitudinal like the in-plane technique. Tennis elbow, you know the common extensor tendons, many names, but you should know the anatomy. Indications like that, chronic vein failure, all of you know this, but this is in plane and this is in plane also, and this is in plane. This is another orientation. Here the probe is longitudinal. Okay? And the needle is going in plane. At this moment, the probe is transverse. But still he is keeping on introducing the needle in plane. These variations you will get because you have a good base. You can build upon that base many manipulation. But at the end, you should put the needle to the target area as accurate as possible. Lateral epicondyle, to have an idea about the anatomy. Common extensor tendon, which is like what? Like multiple fibers like that. Lateral collateral ligament will be not the same anatomy. All of this tendon will join to that lateral epicondyle. Here is the radial head. Okay? Look to the injection here. Lateral epicondylitis, ultrasound guided أذون. أنتوا بتحقنوا أذون أحيانا؟ أحيانا. Here, where is the probe is put like that, and this is lateral epicondyle. Needle coming like this, you will inject at that region. Because you see the needle, you are accurate, you are confident. You remember the basics, we start the day upon it. Okay? You see here the distribution of the material will indicate that you are in a right position. Okay? Gulver's elbow, we jump to the medial side. Okay? The other one is the lateral side. The medial side, nearly the same. Medial epicondyle, and these are the common flexor tendon. Tendons means lines parallel to each other, fibers, brighter. Why it is seen brighter? Because you are perpendicular upon that, okay? And this is the ulnar collateral ligament is here, and this is the ulna, and this is the location of the probe. When you see the location of the probe like this, you see it or not? Did you see? This yellowish line, and this is the body mark. Body mark, this is the probe, and this is the knob of the probe. Means here, the knob is at that region. Okay? The injection in plane like that. This is in plane also. This is in plane. This is the epicondyle.
Dr. Frank Johnson from Sports Medicine Ultrasound, here to demonstrate
sometimes they inject PRP.
medial elbow.
دكتور الأشعة تعرفوا PRP يعني إيه؟ يعني أيوة عشان في كتير من أحيانا ما كناش نعرفها يعني.
PRP injection. First thing I want to interrogate is the ulnar collateral ligament. On the left-hand side of the screen, we can see the distal humerus, or the medial epicondyle of the humerus. On the right-hand side, we see the sublime tubercle of the ulna. Connecting the two of them is the ulnar collateral ligament. The only thing I'm worried about when I'm doing an injection is where is the ulnar nerve. I come around the corner.
Another one of the most important items, where is the ulnar nerve? If you don't know where, you will inject the ulnar nerve. So that let us to hear very well.
And I can see the ulnar nerve sitting just here. So therefore I know as long as I stay on the right-hand side of the screen, not a problem. Can't hit the ulnar nerve. To do the injection, I slide my probe out of the way so I have a short way to travel. Grab a small amount of anesthetic. Again, I know there's some people who are watching who are screaming right now saying, don't put the anesthetic in. You want the anesthetic, trust me. Just a small amount. We've watered down the lidocaine to 0.1%. And 0.1% isn't really enough to do anything.
Do you see the needle from the start of injection? No, you see it after some while. Take care while your experience, try don't do this. He do this because he's expert. As a beginner, no. Try to see the needle from the start of a entrance.
The platelets, but it certainly does make the procedure more tolerable for the patient, because otherwise this is just, it hurts. Okay, there we go. There's some anesthetic into the common flexor origin, and we can see essentially a delaminating tear within the common flexor origin. Don't worry, it's really small. Tiny, 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 but I gotta describe it for the camera. Next thing you know, I've got a 1-inch needle. Pass it into that area. There we can see it within the tendon.
What happened? What happened? Indirectly, you didn't see the tip exactly, but you see the effect of injection. This material. Okay, again.
Give me 10 seconds, we'll be done. 5, 4.
Sometimes if you inject the material, you need to inject more. If you go again, there is remaining pathway of the, or trajectory, remaining air, remaining artifact. You think that the new one is the oldest one. The oldest one is the new one. I will show it in the practical session. One of artifacts. You introduce the needle,
and that
introduce some air.
So there we go. That is a comprehensive treatment, essentially of a small but clinically significant delaminating degenerative tear inside the common flexor origin.
خلاص نمنع. أنا شايف الناس يعني الموضوع طولت معاها وإحنا لسه عندنا الجوينتس جاية كتيرة فإحنا الساعة كام معاكم؟ ل10. I think now we should take a main break. Then after that I will highlight on some points. I will not extend more time in theoretical. I will spend more time in practice for all of you. أيوة, yes. Yes, 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 that's great. That means you get the basics I give. Yes. Yes. To choose in plane or out of plane regarding the regional anatomy is my core objective. You will be the one to choose, but I give you the base upon which you will choose right way to inject. Thank you. ان شاء الله نكمل بعد البريك. كويس؟ في اي اسئله تانية؟ اعترفنا على ايه؟ the sterilization very bad for these videos.
don't have sleeve
Cover.
Yeah,
Probe cover.
sleeve for a probe. I put gloves.
Gloves.
Sterile gloves.
Yes.
And I use sterile gloves and
Yes.
sterile gels, not any gel.
I told you the process of sterilization, actually, it is humanity. To think that you are the one to be injected. One of the most important point, is not the sterilization like this. No, is to cover the probe. Because of what? The probe runs hundreds of patients.
Of course.
And the probe usually, because I'm telling this point because of what? I had experience in that. One hospital, I worked inside that hospital. When I joined the hospital a new member, the field of radiology, what I saw all the techniques of biopsy is done without covering the probe. Just betadine and do. I hate the way. I obstruct that way. I make a problem. Actually, I changed the policy for that region to be completely sterilized. For me, if you follow my videos, you will see all, even in training, you will wear an apron. I will try to help you how to cover the probe also. Okay? Because there is dedicated covers, and sometimes you don't have dedicated cover. You can use the gloves. You can use the condoms.
Yes.
You can use something very new. For me, I teach it 3 weeks ago. The man responsible for clinical pathology bring with him مش عارف اسميها ايه زي البلاستر كده. بلاستر يعني ايه؟ شيت اسمه its name is parafilm. He asked me, please دكتور يعني جرب ده. I take it, I put it in the probe. I was thinking that the image will be obscured. I found it fantastic. I used it in all of my work because it is like plastic. I put it like that quickly. It will be fixed. I will make a video and I will send it to you in the group إن شاء الله. يارا بعد إذنك هنعمل جروب للمجموعة علشان نكونتينيو الانتر اكتيفيتي بينا. بعد ما نخلص الكورس اللي عنده سؤال اللي عنده حاجة أنا هبعت لكم الشكل دي ونسأل على الطريقة بتاعتها اللي عجبتني جدا. و many ways you can use sterilization, you can use cover probe, you can use disinfectants. One more issue is using anesthesia. Sometimes in biopsy of the neck, you are going to go through 5 millimeters. What anesthesia you do? تستخدم anesthesia? Sometimes you need to make this spray and this spray beside the nose, beside the eye. Not good. Sometimes you use, I saw in the dental work, they put something like this, anesthetic gel you can use better than any other spray or another like that. So that this field, inshallah, I can put in the group a video for sterilization. Even this probe after use, we should sterilize. The quality, put the guidelines for process of disinfection and sterilization. I will put it inshallah in the machine, in the
Thank you everyone for coming today. Special thanks for Dr. Ahmed. Okay, and I'm happy to announce for our EOS conference as well. It will be on 11 and 12 of October in Dubai, Fetouh. Okay, and I'm happy to announce that all our guests today are invited for free registration for the conference. Okay. If you need any help with the accommodation, I'm here for you to help you through this. Okay, and I just want to announce that this conference is an incredible conference with national speakers and international speakers as well. Dr. Rouai, he's one of our beloved speakers. Dr. Ahmed al-Sarafi, Dr. Ahmed al-Zayed, and Dr. Who else? Dr. Mustafa Aziz. I'll give the mic for Dr. Lai to speak more details about the conference. And thank you so much. We will join after the break. And I will leave for you a QR code if you want to register. We will be happy. Okay?
Thank you. This will be, it's called Summit in Osteoporosis, Osteoarthritis, and Rheumatoid Management. It will be held next month, 11 and 12. And all the attendants here will have a free registration for this conference. This is the international conference. It is between Emirate Osteoporosis Society, between International Osteoporosis Foundation, and the European Society for Social and Economic Aspect of Osteoporosis, Osteoarthritis, and Musculoskeletal Disease. There will be the big names in osteoporosis management in the world. You know what is called the frogs for diagnosis of osteoporosis. The one who invented the frogs, Prof. Canis, will be in the conference, and he will have a lecture in this conference. So I think it is a good opportunity to meet those people. Welcome to the Emirate Osteoporosis Society conference.
ناخد بريك بقى خلاص يا
You can scan the barcodes. You can scan the barcode here for the registration if you want. Thank you.
النور. بسم الله الرحمن الرحيم. To continue our lecture, wrist joint, wrist, elbow, femur. The idea is to have a knowledge about the anatomy and about the basics of ultrasound, like we said, then to complement this by practice. Practice is a very important to fix the skills in your mind and in your abilities. Wrist and hand joints, radiocarpal, metacarpal, first carbo metacarpal, carpal tunnel, flexor, all of these are items we need to fulfill. And remember, if you use, sometimes you may use color Doppler to check the vascularity, to get the concept to be away from the highly vascular region as you can. Also, to use the longitudinal manner is commonly used to fix in your talent the in-plane method, very important. From distal to proximal, avoid injection into extensor tendons. We can use out of plane methods. Sometimes we can use it. This is a needle. Look to this one to shorten our
Now we're going to show it to you standoff technique. So this is called a standoff technique. Now we're going to show it to you on the...
أحيانا, sometimes you may use a large amount of gel. We name it standoff gel to highlight on an area beside that region of insertion. I will show it to you. You will see
wrist because it works well here, but actually it also works very well for lots of small...
This is a sterile gel. Sterile gel
joints in the hand and in the foot. It's particularly useful where you've got quite clear bony contours, and what the gel does is it fills in those contours to allow good contact between with the probe to ensure that you get a good image. So what we've done here, and obviously you need to use sterile gel, but what we've done here is we've built up the gel.
What is the gel here? This is the area of gel. It makes widen the view, the space to see very well the area of insertion. This is the area of gel. It looks here the black or the sonolucent region
on the probe, and this is called standoff. So what you can see is, and this is why it's called standoff, you can see the gel in the image, and obviously this is the target here. So you can see the articular cartilage. So what you can do, and again obviously it has to be sterile gel, is you can actually put the needle in and you can see the needle and the needle tip in the gel. Now that's got a few advantages, but one of the main advantages is you know what trajectory you're going into when you're about to pass through the skin. So you can see where the cursor is, and that will allow you to make sure that as you go in at a certain angle, you know you're going to get to your target tissue. But it also means that the joint is more open, so you can get the injection in a little bit easier, and often makes the whole procedure less painful for the patient. So as we go through, you can ensure that you're at the right angle, so you can see the needle there, and that will go in at the right angle, and you can just pierce the skin.
Carbo-metacarpal joint injection also, you may need to do it in plane or out of plane, and sometimes out of plane is good because it is superficial. The same video sound. Okay, this probe name, we have one like that. Its name is footprint probe, which is good for the fingers. The same, and it is high frequency probe. You can see high resolution in the image. And here we are apply this sound in this video is very important. Yeah.
And I always think it looks like a koala bear winking. The middle of the room correct. So and it is normally quite an effective injection. I think the setup's really important to get right for this and does make the injection itself a lot easier. First of all, I would suggest that you get the setup of the room correct. So I'm sitting on a stool, patient is supine with the arm down by the side, and you can see that I'm going to be facing the ultrasound machines.
As I told you, you can manage the setup of the patient for your comfortable situation, and you will build your own experience. You will take some information from me, from your colleague, from your own self. You will manage your experience and upgrade it day by
machine.
day.
So what that means is that when I'm holding the probe and I'm trying to line up the middle of the needle with the middle of the probe, I can see the image in front of me as well, and that makes things a lot easier. So the first thing we need to do is just orientate ourselves to the ultrasound anatomy. Now I've got a hockey stick probe here. This is the L6 to 24 on the E10G machine, and it really does give a lovely picture. Now some people do struggle to find the first CMC joint. A few different ways of doing it. The way I find that works for me is I just pop the probe onto the distal end of the radius. So you can see the distal end of the radius here. As you slide down into the hand, you should then see the radial artery, okay, which you can see there. And obviously you've got your veins either side of that, which you can compress. And I always think it looks like a koala bear winking at you. So you can find that, and then as you slide further down, what you should find is a joint. And that's what we can see here. Now, we need to bring a needle from this side of the probe. So we need to make sure
this side of the probe is that side of the image,
that this part of the bone doesn't get in the way. So if we bring it to one side, you can see here, this is the base of the first CMC, and I call this the sort of Cliffs of Dover, the White Cliffs of Dover, which if you're not from the UK won't make much sense, but maybe we'll put a picture up for you so you do have a look at them. They really are quite beautiful. Anyway, so this is the White Cliff of Dover. This is the end of the first CMC joint, and this is what you need to find. So I'm going to go through that once more. Find the end of the radius. Slide down until you see the radial artery and the koala bear winking at you. Go a little bit further and you'll find the joint. Now, we then need to find the White Cliffs of Dover, which is the base of the first, and if I just come around the back of the joint, that comes up. So this makes a really nice target for our injection. It's important that you don't go too far round so the radial artery comes on top of the joint, which you can see that. So don't go too much onto the dorsal aspect. Stay round here. So what we're going to use, you can use an orange needle for this, and we're going to aim the injection into here. Now normally there is some osteophytes which can make it a bit tricky, so sometimes you do need to work around the joint to find a nice opening, and we're just going to aim the needle to here, and often there's a bit of fluid that you can aim for. So we can use an orange needle for this, and what you're going to do, if we just wipe away, obviously you're going to use sterile gel if you're actually doing the injection, and then we're just going to aim into the middle.
Stop here before injecting to highlight on, before going to the target region, you should fulfill your mind by the normal anatomy and how to use the probe to go to the area away from the vascular or nerve or that makes you more safe. So that this preliminary study or preliminary orientation is very important before any injection, to make sure to be away from dangerous organ
of the probe, okay, and we're going to go in probably at about 30 degrees. That'll be about a 30-degree angle, and I want to end up on this region here, or just underneath the capsule. So let's just do this. So you're just going to start nice and close to the probe and in at about 30 degrees.
In plane, started to inject, and we will see now. This is another probe. Also, it is in plane. The joint is here. We will see the way of injection. Okay, it stops. He stops at that level because he sees the tape very well. This is what I told you, out of plane method. During this method, you should know in your mind how much nearly I should go deeper. Sometimes you may measure the needle centimeter. I will go 1 centimeter nearly 1-2 centimeter like that. How to measure? Start from this area, surface of the probe, until that region. You can measure it, but by time you will get this measuring in your concept without measuring it exactly, because I know that I'm not going 3 centimeter. I'm going 1 centimeter, so that during knowing the depth, you can adjust the probe to see the tip of the needle, or to see the nearby tip of the needle. As we know, an out of plane, it is so difficult to see it very well. But in short distance, you can see a little bit like this. These are vessels. Here, the joint. You see the tip. Start. You see the effect of injection. That means I'm in targeted area. I'm correct. I'm accurate. Okay. Carpal tunnel also need more like
sound
that.
Scan in this position because the
I
on
like
everybody.
to jump to
Confident
the base
with
of,
where you are from an anatomical
our
point of
core,
view, and more
like
importantly, you need to make sure you identify
Look
the
to the
median
resolution
nerve
of the
and
image.
the surrounding tendons, and they can look quite similar, particularly in transverse section. Now, if we go further up the arm, you'll see the pronator quadratus muscle, and you'll see in the middle of the forearm something that has that sort of honeycomb appearance, which is the median nerve. And as we go further up the arm, it's in this fascial plane. Now, as we go up, this will make its way more superficially, and that's how we can identify that it's the median nerve. So you can see here, it sort of pushes the other tendons out the way and goes up more superficially, just underneath the retinaculum, which you can see at the top there. And so this is the median nerve, okay? Now, the next thing we need to do is to put that into the middle, and then we need to identify. Very
important point. Look to the fibers of the tendons, okay, ligaments. Look to the anatomy. Look to the bone. During the movement of the probe, the better time to see it very well when you are what? Perpendicular. At the region of interest. You are making a preliminary assessment, go there and come like this. The area you need to inject, try to put it as in a perpendicular manner, 90 degrees, to get a good image, good resolution.
Identify the radial artery, which you can see here, and obviously you can put your power Doppler on, and you'll see that pulsing away. But obviously, because we're going from the ulnar side, we want to find the ulnar artery, which we can see pulsing there. So that means that the distance, we've got this safe area between the median nerve and the ulnar artery. Now, I'm going to show you a technique which is called a standoff technique, which I find really useful, particularly if I'm...
I can ask a question? What is meant by standoff technique? Gel. To make some gel to help you to rename it standoff technique.
Be doing a hydro dissection. So if we put lots of sterile gel into this area, then what we can now do is we can actually get a view where we've got the median nerve, which is going to be this structure here, but also you can see the artery. And again, if you're not sure, then you can just pop your Doppler back on, and there you can see the vessel and you can see the arteries. So we know exactly where they are now. Now if we go back and we get that sterile gel, remember, and we build it up, then what we can do is we can actually, because obviously what we need to make sure we do is to avoid hitting the median nerve. Now this is the median nerve here, and this is the artery in the bundle down here. So we need to make sure that we're coming into this region, and particularly aiming into this area to get underneath the median nerve. Now by using the standoff, it means we keep the artery in view throughout the whole procedure, but it also means that as we come down, we can actually see the needle tip, if you like, before, which means we can actually identify what angle we're going at before we go through the skin. Now that's really important, because if we don't identify it, then as we go through the skin will move, and you may actually end up either going towards the artery with the needle or towards the median nerve. So that can be a really useful technique for particularly if you're going to do a hydrodissection, which needs a little bit more accuracy in the injection.
Is not injecting in that tissue, injecting behind that tissue, okay? Because he is accurate and he see the tip of the needle. You see? Okay. Look to the good resolution and look to the more accuracy in injecting in the required plane. I think we give you a hint about the importance of needle tracing, the importance of tip visualization, the importance of manipulation, and sometimes during your daily work you may meet some challenges. How to overcome these challenges? If you have this base and you make a practice, you will overcome it quickly, confidently, and accurately. Other joints, I like to use the time to deliver to you the core objective of the day is to control seeing the vessel, seeing the needle shaft, needle tip, and like that. I think in internet you can see more and more, and just in this lecture I add to you the importance of combining understanding basics with your experience. If you are working before, try to adjust the experience on working on scientific way. If you don't work before, don't worry, start from this moment, start on chicken, start in vitro, try to bring models, and then make more practice. You will be controlling very well. If you control the needle insertion tip and the visualization and like that, you can do any interventional ultrasound procedure, because you get how to pick the fish. You did not get the fish. You understand this مثل؟ ها؟ ولكن انا بجيب لك الصنارة تصطاد السمكة ازاي؟ بالعربي I should say بقى مش هديك السمكة. فhow to pick the fish, this is talent. Not taking the fish really. Regarding the hip joint, sometimes because the hip joint is an area usually bigger and sometimes patients are obese, you may use or you usually use the deep probe or the curvilinear probe, so that you will put it like that. Remember, if you use it, try to make it parallel with that, because the needle like that and you are like this. Try to make it parallel to see the needle tip important than the shaft, okay? Because you need to be accurate to inject inside the joint capsule. Here is the humeral head, femoral head, and this is the area of injection. Maybe from here, let us to see this video. The tip of the needle now, it is more shallow. But if you compare this shallow with the beam ray, it will be nearby 90 degrees, so that you can see it very well. At injection of that hip joint, you will reach to hit the bone, then go back little bit, and then inject your material like that. Trochanteric bursa, and it's sometimes many pain come in the bursa, and bursitis يعني gluteal tendinopathy. Many diseases need some injections. You can use, and the osteophytes maybe also like that. Let the patient lie in this position, and you can use it in plane but in transverse. Put the probe transverse like this and go in plane like that. You can use it very well.
So just a brief reference to them. The anterior facet of the greater trochanter with the minimus on top. Go to the left.
I think the concept now is settled in your mind. Let me to some the other joints will be in the lecture, and you can see it in the A of quality is one maybe relaxation, but equality equal patient satisfaction. If the patient see the needle, it will be uncomfortable, like breast, for example. If the needle like that, when the woman think that this needle will come here, it is so, and it's a sound also, tuck, tuck. These are many points. Use it in your work. This will market your work very well, and you will make good quality to the patient. As we know, quality means patient satisfaction. I think I should jump because it takes time. I need the time to be spent for every one of you to show me the basics of the today. Okay, to show the you need to see the knee. Okay, okay. Knee joint injection, maybe suprapatellar above the knee cap, medial or lateral patellar regions, and these are the injection sites. Most common causes of injection is the osteoarthritis, like this in X-ray. You can see it in ultrasound like that, and you may need to aspire, make aspiration for a large amount of. Remember that sterilization, as our Dr. Muhammad tell us. Using longitudinal, or using transverse, or using transverse going medially or going laterally. This to orient what is inside that region, okay? Or to assign where you should go to pick or to hit the area or the targeted area, okay?
Next, we're going to review injection of the knee. Before we get started, keep in mind that this is just a demonstration, and normally these are performed under sterile environments with betadine and prepping the area properly. This is just an idea to show the physician exactly the approach that we use in doing injections with the proper needle placement and approach. The most common target that physicians typically inject the knee joint is the suprapatellar recess or bursa. We begin by placing the transducer in a longitudinal plane with the end of the transducer just above the patient's patella.
Longitudinal plane, okay? We may name it sagittal plane sometime. Look to the knob here. Knob means the mark of the probe. This is the mark. That means this area is cephalic toward the head of the patient, and this area toward the distal. Okay? Patella is here, femur is here. Looking to the, this image coming from where? You are looking from this side.
Next, in setup for the injection, I'm going to rotate my transducer
regarding the
plane.
anatomy here, look to the suprapatellar bursa. It's here. This is the femur, and this is patella. Suprapatellar fat pad is important to know it by more work on normal patients. And I think this today is a preliminary preliminary course for the second one to make more advanced course to illustrate all the anatomy at all joints. This is another course. Then the third one is to go real patient training course. If we can do this here, it will be good. If it is not here, you can take 1 week holiday and go to the region, and at that region you may meet. In 1 week you can do at least from 60 to 100 patients, because there is a dedicated courses for that. 1 week for you will make you expert. After taking this base, if there is no base, it is difficult to take it.
With the end of the transducer just above the patient's patella. Next, in setup for the injection, I'm going to rotate my transducer to cross-section. And
he is wearing gloves? No, just a hint, because he making a training, but in real work, never to do without gloves.
Here we can visualize the physiologic fluid of the suprapatellar recess.
Okay, my question now, as an orientation, this is transverse. Do you agree? Do you agree? Transverse scan. Look what happened with the probe with the doctor, okay? Here, it was longitudinal like this.
Next, in setup for the injection, I'm going to rotate my transducer.
He rotated.
To cross.
Where is the knob? It is here or here? Knob is to the lateral, so that
section.
Medial. Yes, this is the left side. To the
and
medial.
Here we can visualize
the knob is in the
physiologic fluid of the suprapatellar recess, which is the band of darkness above the cortex. This will be the target site of our knee injection. The proper landmarks associated with the knee injection are palpating the iliotibial band, which is a structure that runs down the lateral thigh, and in between the iliotibial band and the vastus lateralis is a soft spot, palpated right here. A needle is inserted in this soft spot between the iliotibial band and the vastus lateralis in a direction directly beneath the center of the transducer to ensure an accurate localization. The needle will be guided into the suprapatellar bursa, and lidocaine is typically injected to ensure proper location, and we'll see the bursa expand.
I like to ask you a question here. At that moment, you see the tip? Huh? Not full. You see the all of the shaft? No. This artifact, what is the name of this artifact? No. Reverberation is the lines repeated behind the loop. No. This artifact, I told you before, because it is important. And never inject while using this. Never inject unless you see the tip. This is the needle. And the probe like that, you see the needle, all of the needle. صح? Okay? But if the probe like this, you will not see the tip and you will not see the origin. So that you will see some of the shaft. At this moment, never to inject. Try to fix the needle, don't play by the needle, and try to make like this. Okay? These are very important. I will show it in the check. Here, at this moment, it is artifact, but he continue to concentrate on the tip.
Suprapatellar bursa, and lidocaine is typically injected to ensure proper location, and we'll see the bursa expand.
Now he is concentrating here, and the bursa is expanded, and the visualization becomes better.
In addition to injections of cortisone or lidocaine or other medications, we often aspirate the knee if there is a significant effusion of the suprapatellar recess. If there is effusion
like that, you can aspirate it easily.
By doing this, we use the same approach as the described injection technique. However, initially, we'll use an 18-gauge needle, insert the suprapatellar recess, and drain the fluid out.
Okay. The injection, it is good and simple and easy, and inshallah I'm waiting your work to send it to our group to check about that. Ankle joint, foot, like this, many joints we can inject, and I think the most important now is to jump to the but before jumping, let me to give you this code. Anyone need to connect me directly, this is my social media, my numbers, my. You can take this code now, because we will jump to the practice and hands-on fixing what we said in all the theoretical part of the day. Why this bird like that? It is my slogan. Because I started training process by teaching Doppler for the juniors, and the Doppler means the colors like that, so that I take it my slogan and I follow this bird to go here and there. It is a long story. May I give you small video, 1 minute, 2 minutes, to encourage you to start building community by another way, like that. I have many videos, but I think على ما اجيب الفيديو يا ريت نغير المكان بقى ونبتدي نجهز فين عايزين نشتغل على المكانتين، يعني هناخد 15 دقايق كده تظبيط المكان عشان كل واحد فيكم يشتغل، كل واحد يمسك جوانتي عشان ايه gloves. I need everyone to have gloves. Okay, we will start that work now. My starting, this is out of lectures, This is just refreshment and to encourage you to do good things with your juniors, with colleagues, like that. I started my training courses 2012, nearly 2012 or 2013, by making many Doppler courses for the juniors in my university, Al-Azhar University, and I did each year 3 months successive, يعني each year 3 months. 3 months dedicated Doppler course. I repeated it until alhamdulillah 11 سنة على التوالي, 11 years. The last one is done outside Egypt. So that I like to translate to you or to deliver to you the passion. The passion. Don't live the life to be gaining only. Take and give. Give more than take. This will give you a happiness. You will not see happiness like that. This one of the courses, it was run 8 for the 8th year done in our university. Large number of attendees like that. And the aim is to encourage, to push the science, and this is our main rule in medicine or in faculty or in clinic or in like that. This was course, it was completely free. I am describing this not to be the superhero, no, it's just helping our community to know there is another way of satisfaction. Yes, to collect the money is satisfaction. To give your benefit to people, it is more and more and more. To continue on that, it is بيسموها جهاد أو كفاح أو فكنا بنعمل كده, but we combine these courses with tourism, because in our region in KHALED there is an ancient city in القاهرة القديمة there is ancient tourism. After finishing the course, at the end of the course, we make project presentation for all of the activities. Then we take them to the tourism to finish our day by entertaining training. I told you in the start of this day, our day will not come again. Let us to entertain our day. Let us make this day one of the greatest days of our life. Then, after doing cultural tourism, WHO encourage cultural tourism. This is one of the quality for the university and for your own work. Day by day you will feel satisfaction and you will feel very good things. For all the and gather our colleagues for something entertaining and something have passion and document. Never to document what you are doing. Day by day by day you document like that. Documentation will make me more upgrading myself when I see myself and upgrade what I have mistakes, and never to take never to forget taking feedbacks from the attendees. And today, please, Dr. Ayara, ask the attendees, they get benefit or not? Clearly, transparently, without any shine, because it is life. We will not take anything. All things, do the best. Never give up, huh? Do injection upon scientific days, you will get a complete happiness. Let me to add one video to make you, don't work in your clinic alone. Work with your nurse, with your team, with your management, with the surroundings, with the community. Next month is coming for breast cancer. All of the hospitals like, breast cancer in months. Breast cancer all over the year. Put a plan and never forget to share in these communities. Sharing in communities will build your marketing, will build your ثواب مع الله سبحانه وتعالى. حاجات كتير قوي قوي. One of the training courses we did for breast imaging, after finishing the course, instead of going to cultural tourism, we changed it to make a convoy, قافلة, convey, and we serve at least 100 women in a rural area in Asia. Okay, start to do this in your hospital. You will you will control your hospital. If you make a step forward, your hospital, this is a different person. You are a different doctor. You are not come to collect the money and they are pushing you and you are pushing them. This is bad life. You are here, everyone coming from his country, built this country, share in building this country by community like that. We make this breast. It was not in October, and we go to the rural area. They meet us like that, and we make service for at least 100 women. Mammography, sonography, intervention, and at that hospital there was tomosynthesis, digital, not working. It was brand new machine, not working. We start to work and we put the team. Up till now they are working. Look at the date. It was I think 2019. Okay, at the end we was happy, so happy. And some patients give us, we take a consent.
يا ريت الحملة تتكرر في جميع المحافظات والقرى وكده. ان شاء الله.
And this one of the juniors now she is consultant and she is doing her job very well like that. At the end, documents. After documentation, you will feel, inshallah, a change in your clinic, change in your life, and train your daughters, your sons, by this way. inshallah نشتغل على انا عندي فيديوهات كتير قوي. Let us to jump to practice, and I need all of you to refresh, عشان I need the core of the day is this practice, not the theoretical part. anyone need to drink something and go back? It is good now to refresh عشان نشتغل كويس. But each one should take his glove with his hand عشان يبقى جاهزين.
Okay, doctor, thank you so much. We will start our workshop right now.
Yes.
I would like to take the opportunity to thank Siemens for sponsoring us today. And thanks Dr. Shaima for being with us today. She's the application specialist for Siemens. Feel free if you want to ask her anything related to the machine. And thanks for Dr. Mina as well, because he supported me as well. And let's start our workshop.
لا theoretical ما خلاص بقى احسن احنا عايزين نشتغل بالايد. لا theoretical خلاص. براكتس على البيت ان شاء الله. انا عارف ان بالنسبه لك الموضوع معدي كتير، لكن ايه جاست ريفريش، لان انا عايز حضرتك بعد كده انا بقى الباوربوينت بتاعتنا بديها للجروب عشان كله حتى اللي يستخدم. ما هي بتتعمل بعد ما بنخلص اليوم، لان ما نقدرش نعملها قبل اليوم. لا هنا اهو واحد، هنا واحد وهنا واحد. ابعد يعني 1 و10 كراسي. خلاص نبعد عن بعض بس. لا عشان كل مكنه هيبقى عليها ناس. هلبس ده برضه ولا ايه؟ صح؟ In your clinic, if you wear this, This is marketing. Yes, don't neglect this small point. Small point make your marketing. The patient, usually the patient examine you before you examine him. This is truth. Yes.
Very good. In a hospital, we put machines in radiology. They'll give us an old machine.
Yes, this is a problem usually between this and this, and so that I like building a team better than picking here, no. And one more point: this using needle is not. It does not need more advanced machine. You need superficial. You see? Yes. دكتور اسم الكريم يا دكتور عوض، انت بتعمل ايه؟ لسه تو ستارت عشان نتعلم كلنا. قول لي عملت ايه؟ هتخش من هنا ولا من هنا؟ نب فين؟ طب فين دي؟ أيوة. طب هي دي هنا ولا هنا؟ اوكي، علشان بس ما نبوظش انا عندي تارجتس لكل واحد. كل واحد عنده تالنت، وكل واحد عنده دي خبره مدرب بقى. يعني انت كويس، عندك ايه؟ الجرأه ورحت، وده جميل. خليني بقى اساين شويه تكنيكس صغيره. بس انا هنا هقعد بعد اذنك. هنحضر في وان سيشن كلنا مع بعض، وبعد كده نقسم نشتغل مع بعضينا ايه. انا احب الكراسي تبقى موجوده وتبقوا قاعدين. ليه؟ لا عشان
قعدنا كتير.
لا، هيبقى وراكم حد واقف يشوف كده، اللي شايف 3 بس او 4. فانا عايز اللي ورا يشوف بعد الاذن. يعني الكراسي كده اهوت
ممكن نخلوهم.
ما انا قلت ما هو لازم في حاجات كده يبقى ايه. احنا محتاج ايوه بالظبط كده. ممكن تقعد يا دكتور؟ قولي ليه. One of the major points during work in injection or using a needle, you should sit. You should be comfortable during doing the procedure. You should be comfortable. This is very important. ما تستهونش بيها. انت عارف for what? For your health. مع long run you will have ergonomics and مشاكل في جسمك. ممكن تقعد؟ ما لبستش انت؟ ما هو ده طيب هو ده شغال؟ ده شغال؟
شغال. ده شغال.
الحمد لله. اوكي، let me to start with you دكتور بعد اذنك. دكتور عوض is exception. Anyone coming, I should see he is wearing that, okay? دكتور عوض, this is the probe. This is the knob. You are right-handed or left-handed? If you are right, you should teach yourself to work by 2 hands. Even, okay? By time, you can use both. According to the patient situation and the situation, you may need to do this by this, okay? You understand, huh? Fadal? Left-handed or right-handed? Right? Okay. Okay, inject by your left hand, huh? Here, show me anatomy. Show me anatomy here. This joint, can you pick this joint? This is the second level of training. But before this, show me the needle. Start. Show me the tip of the needle. What you will use, in plane or out of plane? Okay, forget that, خلاص. Show me the needle. خلاص. Don't to go through the picture or the image. Show me the needle. The target is needle. What you should do here before here, you should align the line of the needle with the line of the brew, the line of the middle of the brew, okay, like this. You see the needle? You see, I did not see the image, but I am sure because of what? Because I follow the steps. يلا. يبقى أول نقطة first point is to align first this hand and this hand, because there is another type of injection is named is guided. No, there is a set, plastic set put on the probe, and you will go through this set. أيوة. This way is free hand, the other one is guided. You put something, يعني بتركب حاجة بلاستيك هنا, okay, and then you are going blindly, you will go through. But we don't like this, we don't use this in joints, we use it in endocavitary, prostate, because you are not seeing the cavity inside. You should follow line. There is biopsy presetting here, you will see line, and the needle will go through the line. How come this? By putting apparatus here and sit it, and you will not use the, yes, two ways of guidance, either by sit or by free hand. Now we are using a free hand, and this need more practice. Free hand need more practice because it is quick and easy, and the sit will make delay and end. Yes, high frequency probe, superficial. The names are high frequency probe, superficial probe, linear probe. Okay. You cannot see, but sure you are inside. صح? Okay, fix this. Don't move this. Don't move this. Move the other one. No. You see? Do you see? This is the tips we will not get until you make practice like that. You see it like that, huh? Okay, go outside. Go outside. Go outside. You see? Now you don't have a needle. This is a needle. What is that? Track. Because air inside, huh? Sometimes it makes you confused. But remember that this is an artifact. Okay? Take again. One more. Sorry. انت مجال التجربة. ليه؟ هنبين عليك كل حاجة لانك انت سبقت وخلاص. طيب. I can start beside the probe directly like this, and I can start like this. But this way I will take long distance to reach the organ. This depend upon what? Depend upon what? Where I should go there. If I like to go this region, I can go like that. I can go from away. But the needle length is not reaching. So that many things you will meet. These challenges will be overcome, but after getting that base. يلا اتفضل. You see, he was seeing the artifact. أيوة. Move the probe. Where to move the probe? Your hand like this. Move the probe toward your left hand, other hand. My hand is like this. I will move like this. Like this. I will move like this. ظهرت؟ استعجل دكتورة. This is the tip. جميل. الأول شوف الإبر وبعد ما أشوف أقول فوق ولا تحت. دي one point. Second point, what happened to him now is his hand like this. Why? This is one of the causes. What he should do what? Yes. امسك البروب بفنجر كده ثبته على المكان. لا بص همسك بدول كده اهو اثبت ايدي على الايه يبقى انت ايه not move. All of these are tips during injection. It will help you. لا
Now you are in hurry. That's great. خلاص. That's enough. Do out of plane. Before inserting the needle, assign the region of interest by the image. Where is the region? اختار لك نقطة. Choose. Okay? This is the region. Fix. Wait. Fix that region in the center of the probe. يعني حركة لا انسى ده خالص. Forget this. Image orientation like that? No. I will put it in the center of the probe like this. Or put it at the tip of the near the knob. خلاص. But let us to give you the most important thing. Put it inside the center and try to hit that region. How to adjust to put the needle inside out of plane inside the center. You may have ثانية واحدة. You will have mark like this. This is the center. Try to go to this center like this, align like that. 100% you will hit the target. But you should combine this and that. هو كده على جنب مش في السنتر صح؟ هو جاي هنا. ما تضخش، احنا ليه نضخ دلوقتي؟ لذيذ. احنا عايزين التب، انسى الضخ دلوقتي. احنا هنشوف التب وبعدين نضخ باللي احنا عايزينه. فين التب؟ هات لي التب هنا اهو. هي موجودة صح؟ لا ده انت بعيد خالص، انت بعيد. ايوه كده اه. خش بالتب، انت خش بالتب مش مشكلة. فين هي؟ خلاص. لان انا ايه وانا واقف هنا. بص انت عامل ازاي؟ بص عامل كده، يعني ده رايح كده والبلين كده. لا روح حرك. ده حرك. بص البروب حرك براحتك، انما النيدل دونت موف. عايز تموف جو باك beneath the skin تحت السكين you can play, but I advise you don't move the needle more. Okay. لا ثبت ايدك، وايدك دي تروح على ايه. انا عايز اجيب ايه في الصورة. هات لي حاجة في الصورة. خلاص هنا دي هنا by logic thinking this not in the center, it is side, so that I should go to the side. صح. So that I told you put it in the center by image. يلا حطها في السنتر. هاتها هنا اهو. Okay. I will advise Dr. Awad he should catch or hold many times the probe with ultrasound machine in checking. This is advice for each one of you. I will give him the advice suitable for him. Okay. خلاص. ثبت لي صورة الصورة. ايوه ثبتها في السنتر. اوكي زي كده اهوت. اقوم جاي في سنتر البروب. انا خبطت في العظمه. شايفينها ليه خبطت بتاع. This is بون مش تيشو. الحته دي بون. ماشي. خليها هنا. اقوم جاي هنا اهو جنبها. شفت ومتخيل البيم ماشي ازاي. اوكي. وده اللي بيحصل في البيوبسي بتاع الثيرويد بالنسبه لك كراديولوجيست عشان تبقى انسايد ذا نود ذا نوديول. اوكي. I think that's enough. تسلم. لسه عايز تمشي؟ لا مش انت خلاص غيرك اركب اركب العجل. لا اتفرج لسه لانك انت انا عايز احنا. ايوه لا ايوه كده. عايزينه يقعد الاول. موافقين؟ بص الدكاتره سيبه خلاص يعني. شوف طيبين. اخر واحد مش هتشرب قهوه. المشكله دي هتكلم عربي وانجليزي، بس انجليزي شويه او عربي شويه. احنا كلنا حقيقه كلنا مشغولين وكلنا عندنا وقت، وكل واحد مشكلته اهم من اخر، ودي طبيعه الحياه. ولكن يبقى شيء، احنا جينا ديديكيتد تايم. الساعه كام معاكم؟ 3. ميعادكم تمشوا كام؟ لا في الورقه 6 يبقى انتوا اديتوني من وقتكم لحد 6 وانا بلاند الكوريكولم عشان تمشي في الوقت ده، او ممكن امشيكم بدري شويه او بعدها بساعتين. ساعتين دي بقى بعمل رحله وهدعوكم الى عشاء ولا افطار ولا اي حاجه، دي قصه تانيه. بس خلينا ايه، اتفضل يا دكتور لو حابب، بس هم اجري ولا لا؟ بس خلاص ادفع. لا هو مش هيمشي، بس ازاي هقول لكم دلوقتي مش هيمشي. يس yes, just a moment. Look to me, you inside. Like this, I am out of plane, صح? The concept is, if you are like that, you will see only dot, صح? But if you are trying to come in the plane, you will see long distance from the needle, like that. Let us to apply. معلش ثانية واحدة. This is out of plane. What you see in the image? Where is it? Dot. خلاص. If I go like this and I will make needle, not to move the needle, but here I should move the needle, because I should from the start like that. What happened? I will adjust the probe upon that region. You see? Adjusting the probe upon the tip of the needle. You see or not? Where is it? Is that region? Because two things. One thing is I'm trying to make both in the same plane. I will not 100% reach that. But the second thing is concept of my moving the probe. Not like that. Just to adjust like this. See, both were working with each other. Step by step. Now here you can see the area. If you inject, you will see that tip region. This is the concept. You will meet the challenges. But this concept in your mind, you will not take a mistake. طبعا هي حط الجل قد كده. Okay, what you should do now, show me an area. هتشتغل ايه؟ in plane. push freeze. معلش عشان في جل هنا. اوكي يلا. ايوه انا عجبني اللي عمله ده، لانه راح يشوفها من فوق بعينيه. بس خد بالك he will push you. Don't go deeper. Stop here and show me. You see? يلا go deeper. Here, this side. Because you see, why? Look to the knob. خد بالك النوب هنا ولا لا؟ النوب هنا؟ فين النوب؟ Okay. What happened? It comes from here. What you did? He make turn of the probe. خلاص؟ All over the day, the theoretical part videos are very simple, easy. Come to apply, you will see the challenges. Okay. Now you are going deeper. I need you to be shallow. يعني سطحي. اخرج برا. Like this. But don't inject your hand. يلا. Go سطحي to see the needle. You see? لا شوفوا أحسن. طب أنا زانق نفسي ليه؟ ما الدنيا واسعة. طب ما تيجي هنا اهو ثانية واحدة. اقعد كده. قول كده اهو. يلا. أنا عندي target. الأول وريني النيدل. وبعدين هات التارجت. You see, we should fix the base, then do the target. Where is the needle? You see, just Very good. No, show me the needle again. Okay, stop and show me the bevel good. Slowly make turn of the bevel. أيوة, rotate while you are seeing. These are talent between both hands. لفيت لف البروب لف how to see the bevel? It is like that. Okay, just wait. What is this black? It is air. Yes. Okay, I need you to hit that region. Yes, what you should do? Yes, move. جزار انت جزار.
تمام.
عملت ايه؟ ماشي تمام. It is good. يلا go.
I put my target in the middle of the screen.
Yes.
Okay. Then
and you inject more than one location. During real patient, it's not good to make this and this and this and only one injection. Day by day you will be like that. From the start, here you can test your hand.
here's the target.
Yes, where is the target? This is the target, okay? Okay. In this joint, I need to put fluid inside that joint. Can you do? Yes, very good. Here. Excellent, Doctorna. What he is doing, he fixes the needle and he's trying to adjust the probe on the needle, okay? That's great. Good, دكتور. اسمك؟ أسامة. دكتور أسامة جزار كبير ها؟ أنت خلصت كده؟
لا لسه في out of plane.
Out of plane. يلا. يعني خدوا بالكم اللي بيغلط بيعلم غيره ها؟ فالتريننج انتراكتيف بطريقة اهو.
التارجت بتاعي
ها
هو البرابر.
ماشي اوكي عشان هو شغال بيحن في الظهر. انا عايز انت تنزل جنب ده. ايوه نايس سو نايس اكشولي سو نايس. ها يس يلا give me the other side. Very good. He get orientation and his hand follow his mind, but he is little bit aggressive. Yes, yes. This is my advice for you. Okay? ده دكتور عوض اديك حته. كل واحد هديله حته كده. Try to adjust this during real work. This will make you more professional. Okay? And you are good. Don't worry. And if you came and you cannot do like him, this is not defect. ما حدش فكر ان هو لا. We are training. بأي جهة. Out of plane. Either out of plane like that. يلا next one. Like this. You see? Okay? Or like that. عشان ايدي الشمال بس واخد وضعي، لكن هو من ناحية دي او من ناحية دي. اتفضل دكتورنا. الدكتور مشي ولا اسمه؟ عشان عندنا جوينتس هنا بص كاربو متكربل اهي. If you came here, this is a small joint. You see? This is the joint. Because of that, the chicken is very good model. يعني حتى the smallest chicken is better for training. Not to bring the aggressive. The challenge will come here like that. This joint, I need to go out of plane. يلا. بلاش joint. لا خلينا هنا الأول. معلش. هنا in this situation I need to make it easy for you. The target is to adjust the hand مع needle visualization. You can make like this, okay, to make it comfortable to you, okay, and fix it like that, perpendicular. You see? Nice, very nice, better than دكتور جزار اسمه ايه؟ حبيبي انا بمسك حاجه. ها لا خد بالك يعني اوعى. That's great دكتور. Yes. Don't move this and try to move the probe. You will see better. Move the probe like this and like this, huh? Okay? Don't move the probe like this. Don't rotate. This is a shortcut or cut artifact, huh? Cross cut artifact. Forget. يعني بنجيب جزء من الايه؟ من النيدل. هنا انت لقيتها، بص لقيتها مش جايه معاك، تعمل ايه؟ بص راجع دماغك، ها؟ ريفيو اند يو ويل ميك لايك ذس. بتجيب البلين مع النيدل. بص اوكي، شو مي اوت اوف بلين. مش شرط كده، ممكن تقوم جايب دي كده ها وتخش كده اهو وتجيب. لا احنا كده داخلين هنتعب. لا احنا في الكونسبت بتاعنا قوم جايين بقدر الامكان كده اهو ونشوف. ايوه ما تخشش بعيد. شفتها؟ طب عايز تشوفها احسن تقوم تعمل كده او تعمل كده، مش قوي يا دوبك جاست مليمتر. عندك حرك. ايوه ايوه اهي. اخرج وخش. ايوه جو ديبر مور، جو ديبر مور. اخرج. انا عايز الليجن ده، يبقى انا عمري ما هجيبه لان الميدل قصير. نايس. ذاتس جريت. يلا ان بلين اند اوت اوف بلين هما الستارتنج بوينت انك تشوف النيدل صح. اوكي. ماشين اورينتيشن. يا مريم يا ماريا يا عائشة، ممكن عايز الف المكنة دي كده شوية. هي ليها زرار بس انا مش عارف. لا هي لا بيلف تقريبا. اوكي خلاص ندخل دي كده اهوت. بصوا معايا عشان حلوه وتسلم ايدك. That's good. That's great. Yes. I need you not to inject. No, inject this point. Yes. You inject. No, I need to see. Okay, show me the tip here. Hitting this point. Or hitting. ما انا كل واحد هديله تارجت. ها؟ Wait. For you, I should choose target. Good target. Okay. This is a collection. Try to aspire it. Don't move this. Just assign the area of insertion first. Okay? I need you to hit that region. Okay? He fixed the probe. What you are seeing, you are think like that. No. Be in the plane. Yes. What happened? Probe. Wait. Probe not work like this. We can slide like that. Sliding and like this. Okay? And adjust. Look here. Adjust the plane with the needle. Now it is not in the same plane. أيوة. الحمد لله. ربنا يسترها معاك. انزلاقية ودوران. هتجيب دي، انت هتجيبها. العب بس ايه، يبقى انت عندك الكونسيبت. Fix the area of the needle, the area of the lesion or the target area, then like that. You see? Yes. Look, when you go down, what you did, you got outside of the plane. Keep on in plane. Okay, wait, stop and show me the needle. Remember. Yes. 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 Next one. Out of plane. Joint. Yes. Yes. It is not should be 100%, but just to help you to control orientation of the machine. Now you will go to this joint in plane or out of plane. Out of plane. Yes. But before going, the joint is seen at the tip of the probe. It's here. Put the joint inside the center. Or let us to be like this. You see here, you cannot join. You see, this will happen in the small joints in the hand. Okay. Now that means you should go from here. You get here, and then you go here. Here you go like this. Go more. Yes. Yes. Then adjust the group. Yes, like that. Go deeper and outside. And try don't to hit the probe crystal. This will make the crystal damaged. Yes, bone. No, bone. خلاص. That's good. Can you inject this in plane? Yes. How to do? Like this, or you can get it from her, from the side. صح? First, show the joint. Show me the joint. This is the joint, and this is good. And here we can put stand of gel. But خلاص. You see, you are come from here. Okay, now you will come from here. Relation to mark. Yes. Group movement like this or like this. You see? Just. And now you should be shallower. Yes. Very good, doctor. Adjust the probe to see the needle. حبيبي احنا تشرفنا دكتور أسامة، ونتمنى نشوف الانتراكشن بتاعتك على الجروب، وبالراحة على المريض. ها مش هنساك. ها go deeper, no problem. Yes, now go deeper. Where is the needle? Yes. Okay, خلاص. You are go to the bone. You will hit the cartilage. So that don't go deeper unless you can see the tip of it. And here you first of all this is the joint, and now I will be like that. Where is the needle? You see, it is beside. I need to make it more what? More shallow. Like that. I cannot see. Like this. Yes, like that. Okay. Welcome. المكنه الثانيه احنا عندنا تشيكن ثانيه، ممكن يعني ايه اللي خلص يقعد عليها يوريني بعض الايه اللي ممكن ما يحس. يعني sometimes you may feel that you did not take your time. This is another one to can work and 2 3 with each other اللي اشتغل بحيث ان احنا نغير. بس كلكم لازم تمروا عليا معايا ولا الشطره بتاعتنا ولا بس وهبه. انا شايف شغل على لينكد ان حلو يا هبه. شايف شغل على لينكد ان حلو. هتجيبي ايه الاول؟ بالنسبه لك انت بقى رايحه هتجيبي ثايرويد. خلاص. فين الثايرويد؟ Where is thyroid? This is the right loop and this is left loop and this is the midline. There is a nodule here. يلا. تسلم ايدك يا بنتي. Yes. Okay. يلا show me in plane. Sorry, the out of plane. Out of plane to the joint. راح الحته السهله.
Just a moment. يلا يا ستي. Chicken is a great piece of meat, joints, depth, texture. Just a moment. Yeah. Look to the. لا ثانية واحدة. أنا عايزكم تشوفوا التيشو ده. بصوا لما أجي عليه 90 درجة أنا شايف اللاينز حلوة أوي. أنا مش عايز أبوظ المكنة. عايز أعمل ديبث وأكبر الصورة أوي عشان أوري الدكاترة. ما هو اللي هيقعد للآخر بيستفيد أكتر. الدنيا كده. يلا اعملي ديبث. شايفين الفوكس؟ الفوكس ده هنا. الفوكس هوديها هناك. ارفعي الفوكس. ايوه 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 ايوه. احنا مفوكسين هنا. اوكي. كبري. ديبث. زقيه. لا ديبث اهو. زق الزرار. ايوه ايوه. مور مور مور. This is depth. Okay. In superficial joints you should use this options. Okay. What else? You can شايفين اللاينز؟ ها؟ اللاينز دي حلوه صح؟ مش شايفه. ممكن تعملي زوم. ايوه ايوه. مور مور مور. خد التراك بول تحت. تراك بول تراك بول. نزليه تحت تحت. طب هاتيه هنا. ماشي بس كده. هاتيه لي المنطقه دي. اللاين ده واللاينز دي احنا شايفين الفايبرز بتاع التندون حلوه قوي. لو انا عشان بقى عليها 90 ده. بص انا هاخدها بالعرض اهي. الفايبرز اهي. خلاص ركزوا معايا. سوري in English. Concentrate in these fibers. Now I can see everything well. But if I make it you see, you can see the difference because I start to be away from 90 degree. If I will be 90 degree, you can see the details. This is anisotropy artifact. لما in B mode, because this is B mode. اوكي يلا. لا خليها هي كده هتشوف النيد الاحسن. in shallow in superficial joints use magnification and use this. It will make more visualization, make you comfortable better. طبعا عارف ان ايوه شفت بقى. Now the magnification is higher than the we need to make more deeper. بس كفايه. نزلي لي الفوكس تحت شويه. لا دي زوم. دوس عليه. This is the cursor of the focus. I need it here. ايوه ورجعي الزوم اللي انت عملتيه. بس خلاص هي كده رجعت طبيعي. راح مزنوقه نفسها. Look to the situation. The situation is so difficult. Can make a change. وخدي غيره. روحوا جوينت تاني. مش شرط. جوينتس كتيرة. osteoarthritis in the knee. Yes. Okay. Shoulder. She is left-handed. You are inside. Now zoom. أنا عارف. شايفة؟ You are inside. Good دكتورة. احنا عندنا مية ممكن نحن؟ بتحن هوا. تسلم ايديكي. انت ايديكي ثابتة كويسة. The good idea with Wala, her hand is fixed. She bring the joint and not like this. She bring the joint and fix the joint. والله. Alhamdulillah. Next one.
الفرخه دي مالها واخده البتاع ليه كده؟ الدكتور اسامه كان جزار صح؟ دكتور هبه جزارين مش قوي كده يعني ها والله. الله رايك انت ليفت هاندد كويس. لا كويس. ها انت دخلت ما شفتهوش تعملي ايه؟ ما تروحيش كتير، ظبطي نفسك وبعدين خشي تاني اهو، بس مش شايفه التب كويس. حلو. طب اعملي ايوه تلت بسيط هتشوفي النيدل كويس قوي. لسه نبيك. يلا اوت. جو ديبر. نو جو ديبر هير. اه وريهاني. اوكي. هم عشان دكاتره اشعه ايديهم حلوه بتجيب الايه؟ بتجيب الايمج كويس، مش شغالين سونار، شغالين سونار فده معروف يعني. هاو تو بلين. المنطقه دي شفت بعيد، انت دخلت بعيد ليه؟ ما عملتيش نسبه وتناسب ما بين حجم البروب ومكان الليجن. لا قريبه. تعملي ايه؟ تعملي كده اهو. شفت انت فين؟ لما جيتي معاه اه تخرجي وترجعي تاني. ما اعملش كده، ما اروحش كده، لا اخرج بره خالص وارجع. فين انت داخله فين؟ ماشي داخله فين انت؟ ما انا شايف عظمه ما اروحلهاش. ايوه تقدري تخشي في الارتري ده. ايوه روحي احيني حواليه مثلا لو نيرف ولا حاجه. الله ينور. تمام تمام. ازيك يا دكتور؟ يو ويلكم. يور نيم از؟ نو اي ثينك ذير از جيل. You can go to the simple area, then spine, paravertebral muscles, huh? Sacrooccygeal region, huh? If you make it longitudinal like this, you will see. These are bones in the midline of the يلا امسك كده. spina bifida, huh? spina bifida. يلا امسك. Okay? Yes. First, show me the needle. This way, not try to catch the syringe very yes. By comfortable way for you. Maybe this is a comfortable for you. Okay? Okay. Okay. انت بترتاح. لا النيدل المفروض بريد مسيطر، لان النيدل هو الدينجرس تبقى تتحكم فيها اكتر. bone. You see the bone, you know that you are hitting the bone. Okay, go to another area like this here. ممكن تقولوا لي ايه المشكله؟ لا المشكله، طب اديني الحل ايه؟ Okay, go inside. First, put both in the same plane. This one, this line, with this like that. You see it? Okay. After going inside, okay, go deeper. Don't worry, go deeper. Okay. You cannot see. What you should do, fix this and try to adjust that. Adjust on the needle, huh? Move the probe. No, you are fixing that region. No, move the needle, all of the needle. Yes, you see? Try to be malleable, huh? Okay, forget that. Catch the probe. يلا. Okay, wait and adjust the probe. Where to adjust the probe? Look, let the probe to follow the needle. Now you can see. You are good. Don't worry. Don't rotate. Slide. Leave the probe. You see? Slide like this. You'll see it. You see? Go outside. Yes. Go inside. Very good. Go superficial. Go outside like this and like that. Yalla, go inside. Wait, don't go. Adjust the probe. You see? Yes. Show me the tip. Yes. Go outside. Day by day, we will see it very, very well. On plane. Where is it? Because you are near the center of the room. Very nice. Very nice. Very nice. Ahmed. وحيد. هنجيب صورة حلوة ونشوف النيت. بسم الله. تسلم ايديك. اقف ما تخشش طالما ما شفتوش كويس كله. وبعدين وانت جوه كده اقف بدي وحرك البروب التاني عليه. ايوه. كده او كده هتلاقي انك تشوف احسن. يا دوبك حركة بسيطة. in the line of the needle. ده يقوم يجيبها لك بسرعة. اخرج بره. ايوه. انا عايز دي تيجي الناحية دي. ايوه تسلم الله ينور. بس هاتها لي صح وريهاني. ايوه كده. Go deeper. ايوه. Very good. You are going to this joint. You see? Very nice. Fantastic. Out of plane. انت عارف انك هتخش هنا ولا هنا؟ كنت عارف ايه؟ ما عشان كده بس لازم بقى يخش زي ما هو عايز، مش الليبر هي اللي توديه. Yes, very good. بص انا من ناحيتي، بص لي هنا من ناحيتي. ايوه انت كده هتروح للبريك، كده كنت بره البريك. شايف؟ وريني التب بقى. لف البروب سنه بسيطه عليه. ايوه دي التب. خدتها لي كلها. ايوه كمان كمل اللف. فرو. ماشي التب اهي قدام. حلو قوي. تسلم ايديك. خش جوه. خلاص ارجع بقى بالراحه. نايس. فيري جود. الحمد لله على السلامه يا ريس. الحمد لله على السلامه. على ايه؟ بالعكس انا عايز اللي معاه وقت تاني يشتغل هناك، اتنين مع بعض كده، 3 مع بعض. لا براحتك. ايوه تسلم ايدك، الله ينور. الله ينور. اوت. ايوه انا مبسوط انك ربطت دي بدي، عشان كده انت شايفها في وسط عند النقطه اهي. تعمل ايه بقى؟ ايوه اعمل كده. شوف هوب. طب هتخش قد ايه؟ هتخش كله ولا هتخش اجزاء؟ دي بقى انت بتتحكم فيها حسب الدبس بتاعك. هل الليجن هنا هخش كله، لو الليجن هنا هخش حته صغيره. شوف انت ده او ده. ماشي حلو قوي الجوينت ده، انا عايزك تجيب. ايوه تسلم تسلم. انت رايح كده فانا عايز اروح له. ايوه بس انت خدت الجوينت اللي معاه، سوري خدت التندون اللي معاه، فانا عايز اخده كده اهو لفوق. ايوه تسلم ايدك يا دكتور. روح جو ديبر. افرد وريني ده. لف عليه النيزل هيطلع لك البروب، هيجيب لك ماشي. ايوه ليه بقول لك كده؟ when you are injecting a patient take these pictures more safe. you will tell that if there is مشكله بعد الحاله ما تيجي يقول لك لا انا عندي واخد اهو الدليل بتاعه. عندك افيوجن وعايزين نسحبه اهو الاسود ده. ايوه المنطقه دي، ودي اوستوفايتس وفيوجن. I don't like to hit the osteophytes. I need to be in between. Adjust and ايوه ايوه كده تسلم ايديك. ايوه زي الفل يا دكتور فاروق. عايز الله يسعد ايامكم يا حبايبنا، واحنا عايزين صوره مع بعض كده. ما طب يلا انا بحسب. اصل بيقول لي يا نهار ابيض ام سوري لسه بيقول لي شكرا وماشيين، هغير ده بس. I will change this. لا فين؟ شكرا يا دكتور تسلم ايديك حبيبي. First try to make preliminary check a green area like this. Yes, fix كويس, fix good. Then show me the needle. You welcome دكتور. Keep contact, keep activities in the group. You welcome. حبيبي ربنا يسعد ايامك. يا ريت نتواصل. انا تليفوناتي معاكم وانا تحت امركم في اي خدمه. حتى ايفن مستشفى عندك محتاج تعمل اي اكتيفيتي احنا جاهزين. راديولوجي مع اورثوبيديك من A to Z يعني ان شاء الله. very good. I need you to come here, not here. Show me the needle. How to come here, go back, then make angulation, superficial, go. Don't go until you see. Yes, very nice, very good. No, I need you parallel. Right, okay. Show me, very nice. Yalla, go deeper, go. That's great. Okay, give me out of plane. You will be here or here or here according your needle and the group. Okay, don't go deeper until you make like this or like this. I try to see the needle. Yes, Very nice. The extent of the depth should be in your mind, because I don't like you to go deeper more than needed. If you make like this, you see where is the needle, you see? Move, you see the needle where? First you was here, but you are exactly here. This is very important. Yes, yes, yes. You see? Why it comes here very nice, better than here? Because the two planes, this is the group, the two planes are nearby each other when they are away. Yes. You see? Okay. حبيبنا الفاضل. Yes. Okay. The knob is here or there? النوب لا مارك هنا ولا هنا؟ هنا. يبقى انت هتخش من ناحية المارك. يبقى الصورة فين ناحية المارك؟ الناحية دي. هنثبت ايدينا. ايوه. طيب دخلت وما جاش مع ايوه، حرك البروب كده او كده اهو. Just to move the probe. Yes, go deeper or outside. Yes, outside. I need you to be here. Come to here. Yes, more angulation, more angulation. Yes, I need this area, not this area. More angulation here. I need more angulation to be as my finger. Why it is not appearing all? Because it is not perpendicular. How to do it? You can come, if you have curve, go to the curve and make it perpendicular. Okay, taken out of brain. ايوه براحتك. حلو. فينه؟ شايفه؟ خش على الاخر، خش ديبر وهات لي التب تحت هنا. العكس. يبقى انا هنا الكونسبت ان انا بروح مع الايه؟ مع ال امسك كويس مع النيل. بص انت رحت فين في طرف بص في طرف، روح هاته في السنتر. خش واخرج، ما تحركش دي. Okay, you are needed the region. Okay. Go another area, no problem. Go another area. Come here, on this side. Yalla, show me the outer plane. Here, because you are, huh? Okay. Go like that. يلا حرك. خش واخرج. هتلاقي النيدل بيمشي معاك كده. ما واضحة. هنا وين النيدل؟ بص هنا، بص كده، بص هنا. انت كده عملت القواعد بعيد عنك. حاول تروح. ايوه بس على النيدل اهو. حرك. خش واخرج. حرك اكتر. احنا رحنا فين؟ بيجري منك، بيتزحلق. ايوه الموفمنت اوف ذا تيشوز indicate that the needle is at this region. بس بيجري منك ايوه. ثبت العلاقه ما بين البروب وما بين النيدل. انت في الناحيه دي خلاص، عايز تشوفها اكتر خد زي ما انت كده اهو، حرك، اخرج بره، خش. شايف؟ شوف انت فين وانت كنت تركيزك هنا. فعشان كده ايه الاوت اوف برين، الان برين احسن. اسهل وجميله وبتشوف بتريحك نفسيا. ماشي اوكي. هاتوا الصوره كويس. ماشي. ثبت ايدك، ثبت المكان، وحط البروب صح. خلاص. شوف هتعرف تجيبه هنا ولا لا. بص انت فين، بص انت بره، النيدل داخل بره. ما انا عارف. وده اللي هيقابلك في الحياه الطبيعيه، فتحاول تكيف نفسك معاه. حدد التارجت اريا، جوينت، كبسول، وات ايفر. بعد كده روح الطريقه دي مش هتغلط ابدا. لا خد ماشي جل، ثانيه واحده عندنا جل اهو. يلا جل معاك. ده مش جل، ده بول. ماشي يلا. اوكي. البدايه بعيد عن اللاين. ايوه انت جبتها في اللاين كده. ماشي ايوه اللاين اول. تسلم ايدك. يلا تعالى او خليك زي ما انت براحتك. ماشي. تسلم ايدك. جو ديبر. يس هيد ذا بون. حسيتها. كمل الحركه بتعملها. ايوه كمل الحركه بتعملها. ايوه حرك جوه، اخرج صح، اخرج بره. امبلين هايل. شفت النيدل فين وصل فين عشان انت مش شايفه، فما تعملش بروسيس لما دونت بروسيد until you see the tip of the needle. ايوه تسلم ايدك. ايوه جبتها ازاي لما بدات تقرب الاثنين مع بعض. تسلم ايدك. ما احنا كنا عايزين صوره كده باللبس دوت مع بعض. ناخد صوره مع بعض ان شاء الله. تشرف حبيبي. لا بص بقى، انت هنا عملت عكس اللي احنا عايزين نروح كده والبروب يروح له. هتلاقيه يطلع معاك عشان بون. انت جيت ومشيت تاني. طب تيجي هنا معلش، هاتها هنا. هنا. الساعة كام يا عم؟ الساعة. ما احنا خلاص خلصنا. لا معلش هناخد صورة مع بعض دلوقتي. ايوه اخرج بره. خش اخرج خش. اما عشان انت ايه مش جمع المكان اللي انت هتخش فيه. الجوينت ده، لو الجوينت ده ثبت ايدك عليه خلاص. قوم جايب انا النيدل ده فين؟ انا هو جاي في الوسط ولا ناحيه شويه هجيبه في الوسط تحت عشان ارتاح. قوم جاي كده اهو. عشان البون محاجزني. خلي دي ماليه بالشويه ها يعني كده اهو. لا يستنى 3 دقايق معلش. 3 دقايق. ماشي. انا بس الايم ان انا اجيب النية. عايز تجيب بقى في الجوينت خد وقتك وهاتها. نوزع ونكمل. يوزع ونكمل. يلا هنكمل متخافش. فين هنا؟
Thank you all doctors for attending today. We appreciate that we took some time from your time. Hopefully this course was fruitful for you. I will just start to distribute the certificates. Okay. Dr. Ahmed, he will be in charge of giving you the certificate, inshallah. First, Dr. Anil. Dr. Anil?
Anil?
Yes.
Mishra? You are?
Yeah. Okay. Dr. Kabir? Yeah.
This is yours? No, why? Why? Yes, this is a very good.
Thank you, doctor.
Thank you, sir.
You're welcome, and I hope you enjoy the day and take some information. Yes.
Hands-on training was very
Yes. Thank you. Thank you.
Dr. Muhammad Gabala? Dr. Muhammad, he left? Okay. Dr. Haytham? Dr. Haytham left. Dr. Khaled? Yeah. Oh, okay. Dr. Abida? Dr. Abida? Okay.
دكتور عوض الميرا. عوض مشي أول واحد ها؟
دكتور لؤي.
دكتور لؤي؟
Yes.
حبيبنا الغالي تشرفنا والله. تشرفنا. You're welcome.
Dr. Burjish, Burjish, right? He left as well? Okay.
دكتور أحمد أيوه شهادات. مين يا أحمد؟ يا أهلا بك. يا أهلا بك.
Dr. Ahmed, welcome, doctor.
يا رب يكون استفدت يا أحمد. إن شاء الله. ربنا يوفقك يا ولد. مستنيين تورينا لسه اشتغل.
Mrs. Nisreen Ahmed? Nisreen? She left.
Howla?
Dr. Kiran? Thank you, doctor, for coming today.
Kiran Sasi. You're welcome. You're welcome.
Dr. Pawan Padam, right? Pawan, yes. He left. Dr. Humam.
Hammam. شرفنا بيك يا دكتور حماد، والله اتشرفنا حبيبي، الله يجزيك خير ويوفقنا ان شاء الله. انت حضرتك منين يا دكتور؟ منين؟ منين؟ عرفت عشان كده ممنون. منين في العراق؟ بغداد، مدينة الطب. انا رحت اول كورس عملته كان ده في مدينة الطب سنة 2007 اول يناير 18 مع الدكتور حسن التميمي كان ماسك مدينة الطب بتاع العراق. انا رحت محافظات العراق كلها يعني. شرفنا يا دكتور والله. اوكي احنا انشغلنا في الكلام صح؟
دكتور أبو بكر. دكتور هبة. Yes.
هبة ما جاتش.
She's not here.
والله هبة دي مميزة. الناحية الثانية. This is out of plane. She was in plane here, comes out here. Why there is a secret? صح؟ أنا عارف السكرت. مش معقول. جيت الناحية دي ليه؟ أيوه. يبقى نيتك حلوة.
دكتور محمد. Yes, دكتور محمد فاروق.
حبيبنا محمد فاروق، ربنا يوفقك. تسلم ايديك واحنا اتشرفنا بيك النهارده. شرفنا ابو حميد.
دكتور ولاء.
ولاء هنا ولا هنا؟ لا
هو في سر ناحيتي.
شرفنا ولاء والله. تسلم ايديكي زي الفل ما شاء الله.
دكتور محمد السيد. He left. Okay. جيش اعتذر. دكتور سيد. دكتور سيد.
محمد رمضان.
No. دكتور محمد رمضان. He left. Okay. خلاص. Thank you doctors for attending today. Thank you so much. Thank you دكتور أحمد.
نحن شكرا ليك على المجهود وشكرا لأستاذة عائشة.
شيماء.
بصي أنا شفت أسماء كتير قوي عشان كده اعذريني يعني.
I'm Dr. Yara, Education Coordinator for MHC. Please feel free if you want to ask for anything. Hopefully you have a look at our course agenda as well. So if you're interested in one of the courses, I'm here to answer any question. Last but not least, I would like to remind you about the Orthoporosis conference, inshallah, EOS, on the 11th and 12th of October. Okay. And we are waiting for you, inshallah, to see you there. Thank you so much. Thank you.
هي دي بتتحرك. لما دي حركت كتير ما عرفتش تشوفها. ايوه انت انسايد. حبيبنا. عليكم السلام، شرفتنا يا دكتور، ربنا يوفقك. نتقابل تاني ان شاء الله باذن الله. حبيبي يا غالي، ربنا يعزك. سيب ده خالص، ريلاكس خالص، خد اليمين، شوف هتروح فين. ايوه ثبت المكان، خش ان بلين. تسلم ايديك. انا من الجنب شايف دي بعيد عندي، تقوم عامل ايه؟ خد دي كده، بص هتلاقيها جت.